We're live, David.
Hi, good morning, everyone. Welcome to this virtual meeting of the Health Policy Commission's Market Oversight and Transparency Committee. We're very pleased to have you here today for a packed agenda of some really new, exciting research and conversation around healthcare and, of course, the impact of COVID-19 on our work. I'm joined today by a number of commissioners of the Health Policy Commission. So quickly want to recognize the chair of this committee, Professor David Cutler, who will be leading today's meeting. Also here today are Commissioners Ron Mastrogiovanni, Cassandra Roeder, Commissioner Cohen, Commissioner Blakeney, Commissioner Lord, Commissioner Berwick, and I just saw Commissioner Chris Kreider. So we have thank you so much for joining us for this meeting. This meeting will be followed immediately by a virtual meeting of the Care Delivery and Transformation Committee starting at 11 o'clock. As always, the materials from these meetings is posted on our website and linked to on the YouTube bio link. Today, we are also releasing a number of publications, which will also be included on our website on our homepage. So recognizing a full agenda, I'm going to turn it right over to Professor Cutler, chair of this committee, to kick off today's agenda.
Thank you, David. Thanks to all the commissioners for joining. I hope everyone's doing well. And David and Colleen, thank you so much for everyone at the HPC staff who's figuring out how to get an enormous amount done, even in a period where it's very, very difficult to do all that. So we have an absolutely packed agenda today with a number of really important topics, so I'm eager for us to discuss them. The first thing we need to do is to approve the minutes from our meeting in May. That was an online, a Zoom meeting, excuse me. So let me first ask whether anyone has any amendments to the minutes. Okay, if there are no amendments, then I think we are open for a motion to vote on the minutes.
So moved.
Okay, and then is there someone who would second the motion?
Second.
All right, so now because we're doing this by Zoom, I'm looking at my box with Lois, we need to have a roll call vote. And she's nodding at me, so
That's correct.
I've said the correct thing. So Colleen, will you do the roll call for us?
I absolutely will, and I'll just ask the members of this committee to vote. So starting with the chair, David Cutler.
Approve.
Commissioner Lord.
Approve.
Commissioner Mastrogiovanni.
Approve.
And Commissioner Roeder.
Approve.
And that's unanimous. Thank you.
It says Commissioner Foley was at the meeting, but he's not. Is he not here now? Is that?
He's joining a few minutes late.
Got it. Okay. So we have, thank you, Colleen. So we have several really just incredibly interesting things to talk about. And so the first one is going to be on serious illness and end of life care, which is just like an immense issue anywhere where there's academic medical centers is going to be a huge issue, but particularly in a place like Boston. So what I'm going to do, I'm going to turn this over to David Seltz, who's going to introduce the issue, tee up the issue. Sarah and Hannah James will do some of the presentation, then we'll have discussion of it. And I should say the discussion is for everyone here, not just those who are voting on the minutes.
Great. Thank you, Commissioner Cutler. Before we dive into the end of life care, I did want to just plug another reminder for our upcoming 2020 healthcare cost trends hearings, focusing on COVID-19 and the impact on the Massachusetts healthcare system, what we're calling assessing impact and advancing equity. We're really pleased to announce a wonderful keynote speaker, David Williams, who will be kicking off our agenda on Tuesday, October 20th at 9 a.m. This is a fully virtual event. But you can register. You can see a link there included on this slide to register and to attend this great event. We're thrilled to have David Williams. Also pleased to announce that Governor Baker will be providing some welcoming remarks via video as well. So mark your calendars. We hope to see you virtually at this event on Tuesday, October 20th. Moving into today's agenda, wanted to return to this topic of serious illness and end-of-life care. We had intended to hopefully present on these slides at the last board meeting, but had such robust conversations, we decided to move it to this committee meeting so that we made sure to give it time and attention, as it is such an important issue. And really so timely in thinking about the preferences and wishes of residents with relation to COVID-19. And for many of you who have been reading in the Boston Globe recently, a pretty powerful spotlight series on related to these issues as well. This is in a series of briefs that we have done on end of life, where we have tried to update and improve our methods for examining Massachusetts Medicare data to understand the experience of Massachusetts residents at this stage of illness. So with that, I'm very pleased to turn it over to our research team to walk through these findings. And again, encourage commissioners to ask questions along the way and to think about some of the policies and implications for this work and for our work moving forward. So turning it over to you, Sarah.
Thank you, David. Good morning, everyone. This presentation will review our work on care at the end of life in Massachusetts, comparing what care looks like in Massachusetts with the rest of the country, and with a particular focus on the care that people of color receive. So, high quality serious illness care is defined by addressing patients' medical and emotional needs, with patients receiving care based on their individual preferences and priorities. That could be preferences for less intensive care, that could be preferences for more intensive care. However, numerous factors result in differences between best practices and the care that is actually received at the end of life, particularly for people of color and people with lower income or education. According to a 2018 Massachusetts survey, 29% of people with a loved one who died in the past year said that healthcare providers did not fully follow their loved one's wishes. And people of color were more likely to state that their loved one's wishes were not fully followed. Next slide, please. So early communication about preferences has been shown to lead to higher quality care, but those conversations often don't occur. Aspects of communication that impact outcomes include addressing patients' emotional needs, awareness of the prognosis, awareness of treatment options, goals for care, spirituality, and costs of care. However, only 27% of adults in Massachusetts with a serious health condition reported having any conversation with a healthcare provider about end-of-life care wishes. And that's not even to say, that's just whether the conversation happened or not even speaking about the quality of the conversation. The conversation is the most important, but documentation of preferences is also important. And among older adults in the US with serious illness, white adults have been found to be more likely than Black or Hispanic adults to have documented their wishes for medical care. This is unfortunately a very timely topic given the context of COVID-19 and its exposure of health inequalities. The quote on the right, I think, is a good example of the context of COVID. However, I actually want to substitute in a quote that was in the recent Excellent Globe series. This situation is, this quote describes a situation that happened in 2016, long before COVID-19. The quote is, "Even as her cancer progressed and her symptoms worsened, Gertha, a Brockton resident, never saw a palliative care specialist. She never saw a hospice worker until the day before she died at Good Samaritan Hospital in 2016. Her youngest daughter said, 'She was in agony and I don't think it was called for. The pain was really brutal.'" Next slide, please. So looking at patterns of variation in intensity of care can often indicate a need for quality improvement. And that is because there's a very large body of research that shows substantial variation in intensity of service use at the end of life throughout the US and even within Massachusetts based on previous HPC work, which cannot be explained by differences in patient preferences. On some measures, there would be a variation of twofold that's across the US and even within Massachusetts on particular measures. So even though that variation cannot be explained by differences in patient preferences, not with that magnitude, individual preferences for care do play an important role. Research suggests that most people, this is vast majorities across all groups, prefer less intensive care at the end of life. However, Black and Hispanic patients are more likely to express preferences for intensive care at the end of life than white patients. That is explained by a number of cultural and socioeconomic factors that are associated with preferences for intensive care, including greater religiousness, living alone, less knowledge of options, not having a regular doctor, and distrust of the healthcare system. Black patients, in particular, are more likely to believe that they would receive lower quality treatment if they completed an advance directive, stemming from real historic mistreatment by the medical system and real concerns based on receiving lower quality care and worse access throughout the lifespan. While individual preferences for intensity of care vary, literature is quite robust in showing that health system characteristics and provider practice patterns have been found to be the most predictive factors of variation in care. That's by region, between groups. Recent studies, for example, have found that controlling for the site of care largely erases differences in care received by race and ethnicity. Next slide, please.
Could I ask
Sarah,
a-
before you move on, we just had a question.
Thank you. When we document our wishes, does the point in time when we did document that make a difference if the person is receiving end-of-life care, let's say 10 years later? Does that make a difference? From my experience, I found it does. So I was just wondering, and I'm going back a lot of years, but I'm just wondering, is that still the case?
Well, I think the ideal situation is that is that conversations are ongoing, preferences are ongoing. If preferences and wishes change, documents according to that should be ongoing. And in particular, advanced directives also include naming healthcare proxy of someone who can speak to your wishes and guide care if we're unable to communicate ourselves. And ideally those conversations with that individual are ongoing to represent sort of the most current state of our preferences.
Stuart, if I may, I think a couple of additional things need to be identified. And one is that this needs to be recognized between the provider and the patient that this is an ongoing process. Patients and families need to have ongoing discussions, especially as life circumstances shift and change. What I consider to be valuable today as a fully functional human being is very different if I've had a heart attack or if I've had a stroke. What I value then is different. And so it should be an ongoing discussion, and all parties to that discussion need to make it a regular, not difficult process of conversation. That's when it becomes valuable. That's when it really makes a difference. So yes, Sarah, it's not a one-time conversation. It can't be thought of that way. And in my opinion, I think it's the provider's responsibility to periodically revisit that conversation, because they're the ones that perhaps understand the process best. So yes.
Thank you very much for those comments, and we'll get more into that topic in a few slides. Thank you. So turning to our findings and data sources. Next slide, please. So we used publicly available Medicare data to examine differences in care by race and ethnicity in Massachusetts, using Dartmouth Atlas data on metrics of service intensity in the last 6 months of life and different public use files and other sources for hospice use and new Medicare code for advanced care planning. And our research brief that has our full set of findings is now available online. I'm very excited about that. So thank you. Okay, so starting with hospitalizations, Medicare decedents in Massachusetts have more hospitalizations than in the US and the rest of New England, but substantially less ICU use. These are the blue bars on the left. So an average of 1.34 hospital admissions in the last 6 months of life in Massachusetts, higher than in the US and the rest of New England, and 37% less ICU days. However, Black patients are more likely than non-Black patients to be hospitalized. And if they are hospitalized, they are much more likely to be in the ICU. This is the set of bars on the right. This trend is true in both Massachusetts and the US. The difference is smaller between groups than in the US, but still very large. So that is 14% more hospitalizations between Black and non-Black patients in Massachusetts compared to 25% in the US. In terms of ICU days, Black patients have 36% more ICU days than non-Black patients in Massachusetts and 50% more in the US. So turning to location of death, next slide, please. These are sobering findings. Massachusetts has among the highest rates of death in the hospital in the US. Massachusetts has the 4th highest percentage of Medicare deaths that occur in the hospital among Black decedents, and the 5th highest percentage for non-Black decedents. Among non-Black decedents, that's 23% of Medicare deaths occur in the hospital, and fully 28% of deaths among Black decedents. Next slide, please. So we also see that these trends in location of death are increasing over time. This graph shows trends from 2012 to 2017. Years are averaged together to have a smoother line. That's why these are slightly different than in the previous graph. So we see that among non-Black Medicare patients in the US, the share of deaths in the hospital are decreasing over time. That's the dotted blue line. They're fairly stable among non-Black beneficiaries in Massachusetts. That's the dotted orange line. In the US, among Black decedents, the trend is also decreasing over time, quite consistent with the non-Black trends, the solid blue line. However, looking at the solid orange line, Black decedents in Massachusetts, we see that unlike the US, deaths in the hospital have been increasing from 2012 to 2017. And for our next set of results, I will turn to Hannah James.
Thank you, Sarah. Hospice is a comprehensive palliative care service which aims to address pain and other symptoms while providing emotional support for a patient and their caregivers. In order to be considered eligible for hospice paid for by Medicare, a patient must forego curative services, and a doctor must certify that a patient has less than 6 months to live. Hospice care is associated with less pain and higher quality of care at the end of life. Despite the known benefits of hospice care, only 47% of all Massachusetts Medicare beneficiaries who died in 2017 were enrolled in hospice at the time of their death. This is slightly below the national average of 48%. Among Medicare decedents who did use hospice in 2017, about 1/4 used the service for 1 week or less in both Massachusetts and the US. There is no explicit standard for the ideal amount of time for a patient to receive hospice care, but providers should aim to maximize the benefits of hospice care for their patients and their families. Next slide, please. When we consider the connection between rates of hospice utilization and the percent of Medicare deaths occurring in the hospital by state, as Shara showed earlier, we see a very strong relationship. This figure plots the correlation between the percent of Medicare deaths occurring in the hospital on the y-axis, the vertical, and the percent of Medicare decedents enrolled in hospice on the x-axis, or horizontal. We see that states with a higher percent of Medicare decedents enrolled in hospice tend to have a lower percent of Medicare deaths occurring in the hospital. Next slide, please. Now let's look at the patient populations among all beneficiaries, including those who died and those who did not, and consider who received hospice care. What we see is that beneficiaries of color receive less hospice care compared to white beneficiaries in Massachusetts and nationally. The gaps in hospice service use are larger in Massachusetts among beneficiaries of color. And again, the percents of hospice use are lower in this figure compared to the prior one because this is among all Medicare beneficiaries, and on average, about 5% of Medicare decedents die each year. Next slide, please. As Sarah mentioned earlier, advanced care planning is essential to ensuring patient-centered care and care that is aligned with the patient's values and preferences. And as Commissioner Blakeney mentioned, it's really important that these conversations are ongoing throughout a patient's life, even well before they're considering the end of their life, but also throughout that care process. CMS first introduced advanced care planning codes in 2016, and data on service utilization for these codes is available for 2016 and 2017 presently. This is a first look at early data from billing of this code, and it's important to note that advanced care planning can occur without a provider billing for the discussion with this code, so the rates reflected in the following slide are likely an underestimate. Next slide, please. Early trends in the adoption of the Advanced Care Planning Code are promising, and the rate of utilization doubled between 2016 and 2017 in Massachusetts. The rate in 2017 was higher than the national average and the rest of New England. The number of unique providers who delivered at least one advanced care planning service grew by about 50% in Massachusetts and the US in 2017. As I mentioned, this is a really promising signal. But as we'll see in the next slide, please.
Hannah?
Yes.
I think Ron wanted to go back one slide for a question.
I'm so sorry. I can't see everyone.
I know the feeling extremely well. Ron, you're on mute.
I'm sorry, I didn't have a question. Didn't.
Oh, my fault. My fault then.
No worries. We can go to the next slide, please. Thank you. There is wide variation in the rate of advanced care planning service utilization throughout the country based on 2017 data, again, the most recent available. In a national context, Massachusetts, our orange bar on this one, ranked 16th for the rate of advanced care planning service use among Medicare beneficiaries. We'll continue to follow the use of this code in coming years and continue to look for other ways to evaluate how these conversations continue to evolve as more beneficiaries use advanced care planning. I'll turn it back to Sarah for the remainder of the presentation.
Anna, can I just ask one question or maybe more a comment? I think there's, I liked everything you showed. I think in some parts of the country, not Massachusetts, thank the Lord, hospice is a bit of a scam. Mm-hmm. That is, people, hospice providers go through the hospital and say, hey, would you like extra benefits? Person says yes, then they sign them up. Then the person says, I want my chemo. And they say, oh, well, fine, just disenroll. And then when you're done with your chemo, just come back in. And so I think it's very hard to compare hospice use in the US versus Massachusetts because there's some of that goes on elsewhere. So in some sense, I think the absolute numbers are more important here than the relative numbers because of that. I think on the absolute scale, what you're showing is that there's some things that look very good. Like it seems like there's a lot of use of the advanced planning directive, and then some things that are very poor, like people getting hospice care at the very, very end of life and people dying in situations that they would prefer not to. So I think it's a mixed bag, but I guess I don't want to I'm not sure, like there's certain small areas of the country that do it well, but the vast part of the country just does this really poorly.
Yeah,
I think
I think that's a great point, and I think I would just highlight that, as you mentioned, in Massachusetts, there's been a lot of really great efforts in the space of a serious illness care that have helped both providers and patients understand what hospice is and when you should be enrolling in it, to make sure that not only are you not missing out on an opportunity to continue to improve the length of your life, if that's what you value most, but I think a shift more towards the prioritization of the quality of life, which is what most patients tend to value, particularly in serious illness care. So thank you for that comment.
Let me also address one point. Those dynamics are certainly true in the hospice benefit. However, they are, I think mostly that you really see those patterns show up in the length of hospice use and patterns of live discharge, as you described. And since this chart of hospice use is defined by received any hospice services, I think that those sort of perverse incentives in hospice may not be really playing out there as much. But your point is well taken. Okay, if there aren't questions, I think we can move on thank you. So because the data on advanced care planning that was available to us doesn't capture differences by race, we've drawn on the literature, which indeed suggests that providers are less likely to initiate these conversations with patients of color. There was a 2016 study in New England that found that Black, Hispanic, and Asian Medicare beneficiaries were significantly less likely than white beneficiaries to have a claim for these discussions. However, there is good news that early national data suggests that these disparities are narrowing. As Commissioner Blakeney said very well earlier, clinician perspectives and resources play a critical role here with approaches that facilitate more equitable advanced care planning, including appropriate training and resources such as translation services, rejecting stereotypes, and assessing the preferences of the individual sitting before them rather than assumptions based on membership in a group. Next slide, please. So in summary, the large variation that we've shown here suggests that high proportions of Massachusetts residents don't receive care in accordance with their wishes. We are hospitalized more than in other states. We are more likely to die in the hospital, and fewer of us take advantage of the hospice benefit. Each of these factors is exacerbated for people of color. Given the importance of conversations, the last point here is are promising trends in growing use of these conversations. Next slide, please. So finally, we wanted to conclude by touching on a few opportunities for improvement and really wanted to highlight here the Massachusetts Coalition for Serious Illness Care, which has been a real leader on this issue, coming together in recent years and including more than 100 organizations as members to focus on this important topic. The coalition has recently partnered with the Conversation Project and others to develop tools, particularly in response to the COVID-19 pandemic. And there are promising developments with Massachusetts ACOs, with many reporting providing training for clinicians, although this is also an important area of focus with building on that foundation to have more training and more resources to improve initiation and the quality of conversations equitably. And in particular, continued quantitative and qualitative data monitoring from a range of sources, including patient perspectives, which are all essential to support high quality, equitable care for all populations at the end of life in Massachusetts. So with that, I'll conclude and we welcome any questions. Thank you.
Thank you, that was great. Don Berwick, I don't know if you're on, can I call on you to talk a little bit about what we know about how to get this to get this to work better. And then Barbara, if you can have any thoughts you want to add in after that, I know you've already added some.
Thanks, David. Well, I first, by way of disclosure, the Conversation Project was at the Institute for Healthcare Improvement, where I still have a relationship. So I'm related to it. I think that's been one of the most informative sources of information on what you're asking me, David. There are two parties involved here. There's the help to families to have the conversation around advanced care planning in an anticipatory way, not in a reactive way. And that involves a lot of outreach, a lot of education, and it's an ongoing struggle. I think the resources of the Conversation Project that they've developed, the tools are very good and effective. I would also say that there are benchmark communities in this country, La Crosse, Wisconsin, Salem, Oregon, and others that have made astounding progress, approaching really almost 100% coverage with advanced care planning. And it's worth looking at those communities to see how widespread community cooperation has led to the conversation to more readiness with advanced care planning. The second, though, is the other side of the coin, which is what the Conversation Project calls conversation-ready organizations, because it's not just enough that the patient and family have tried to think ahead which is hard to do, but the organizations have to be ready to take up that information and map it into their care processes. And that's an equally important enterprise. I'm happy to see the progress with the code, but I also noticed there's a big gap. I mean, even with that progress, there's a substantial gap to close. But I'd say that's a way to think about it: how to help families confront this challenge of doing this and give them tools to do that, and then really working with the healthcare systems on conversation readiness. I think the last point I'll make has to do with a very exciting endeavor around age-friendly care, which is related to this. This is part of a larger enterprise in healthcare now nationally that's being sponsored by the John A. Hartford Foundation to help all healthcare organizations be, quote, age-friendly, in which this is part of that, to be ready to do what matters to people. I don't know if that's helpful, David. That's some of my background.
Thank you. Let me ask Barbara if she wants to add anything, and then Tim, I saw you had your hand up, so let me get you after that.
David, thank you. I want to strongly support the comments that Don has just made. The project that he referenced is a critical tool to help frame the conversations, and the conversations can be extraordinarily difficult to have. It's best to have them early. It's best to have them more frequently than people think. I think the article, the series of articles in the Globe this past weekend was extraordinarily helpful in framing part of the conversation, especially as we look at the discrepancies between white and non-white populations and what happens in end of life, which is, as was noted in the slides, significantly and statistically different. And how do we start to think about engaging in those conversations that help minimize those differences, to help change those and get more equitable with the services and resources. And then I think the last thing I want to say is that oftentimes the challenge to offering palliative care, which we haven't talked about, and hospice care, is a reluctance on the part of the clinician. When a person is in hospice less than 24 hours and they die, that's unfortunate. It means that the resources available that hospice had to offer that person didn't get offered until the very end of life. There's much more to hospice than that. There's much more to palliative care than that. So engaging in those conversations to help clinicians and patients and families take advantage of the available resources in a time that's more beneficial to the patient and the family is something that we also have to make sure we have conversations about. It's one of the major stumbling blocks for both palliative care and hospice. Thanks, David.
Tim, you want to come on in?
Yeah, thanks. I just had a quick question. This is very informative. This is an area, to be honest, I don't know much about, so learning quite a bit as going through the presentation. I'm just honing in on the health equity considerations summation here. I'm just wondering what do we think the impact could be if the diversity or the lack thereof of diversity amongst clinicians, and wouldn't a policy recommendation or something for us to keep in mind and push would be to really focus on diversifying the clinicians? That might be helpful in alleviating some of the discrepancies that we're seeing in the data between non-white and white folks. And I'm just wondering, has there been any research on that or any work being done around diversifying the work, the clinicians themselves, that may be helpful in alleviating some of the concerns that are being raised in the slides?
That's a that's a great point, and certainly there is research that highlights that that clinicians are, the great majority are white, of doctors who are having these conversations, and that is a factor that has been shown in literature of comfort having conversations, and I think that speaks to both diversity among physicians and other advanced clinicians, and also the use of auxiliary staff where appropriate, of having chaplains, of having social workers that have shared backgrounds with patients.
Don, let me give you the last word.
Could I, David?
Oh, sorry. So Don and then Chris.
Thanks.
My apologies, Chris.
Okay.
Yeah, one other quick comment. First of all, thank you to staff for a superb presentation and background. I think people should be aware of a key piece of research now done a couple of decades ago called the Support Project. It's still our foundational understanding of patient preferences and where they lie. It's a really important study, which was done nationally to see really what patients do want at the end of life and what they get. The Support Project documented that neither patients nor providers wanted, most patients and most providers don't want kind of kitchen sink care, a lot of ICU care, a lot of intervention at the very late stages of their last illness. Like staff, everyone I think that I know believes if patients want that kind of intervention, they should get it. This is not a matter of requiring patients not to have interventions, but most don't want as much as they get. And there was this interesting disjunction, even though caregivers said we really shouldn't be throwing the kitchen sink in right now, even though families and patients said we don't want the kitchen sink right now, they were still getting it. And that still remains the case. There's a lot of intervention going on that people actually don't want. Why, I'm not sure. And a lot of people who work in intensive care say they seem to have the belief that the patients are asking for a ton, but we need a deeper understanding of what that pattern is and how to have that conversation so that we actually get what the patients want and what the caregivers do in register. But the Support Project's important and should be part of should be in our visual field. Thanks.
But if I recall it correctly, it also concluded that when it tried to intervene to improve the situation, it couldn't. Like it was not effective at doing that.
In those days, that was still a couple decades ago, but it's yes, exactly right, David. Thank you.
Chris?
Thanks. A couple of points going back to Ron and Barbara 20 minutes ago, just to underline how complex this is. People do change their perspective between decisions they make when they're healthy and decisions that they face when they're mortally ill. And I can say personally, I've seen people patients who signed advance directives and signed healthcare proxies where at the end of life, they change their mind. And there's an old axiom that the people you think are going to be the most comfortable in the last chapter are often the least, and the people who are the least comfortable, you think are the least comfortable, but tend to be the more graceful. It's really complicated. It can be a paradox. And to Ron and Barbara's point, it does change over time. The main point I wanted to make is the data, which is was just great. The staff's done a wonderful job compiling it. I think every slide had a small reference to the reality that this is fee-for-service data. And fee-for-service, by definition, promotes fragmentation of care. It's the absence of coordinated care. And so we have fewer advanced directives and fewer healthcare proxies, excuse me, more death in the ICU, more death in the hospital, decreased hospice, and so on. I suspect that as we get more and better data with regard to the Mass Health ACO initiatives, once we start looking at more Medicare Advantage data, we'll see improvement of the numbers. Probably not dramatic because it's early stage in the movement from fee-for-service to true value-based care. I think value-based care is better care. It does really force the engagement between doctors and patients on issues like this. So I hope we can get some of that Medicaid data and some of that Medicare ACO data. And if it's going to be 2 years before we do, maybe we can look at a proxy for that. And I would suggest the Kaiser Family Foundation data on this subject. Don may know whether or not Kaiser has generated good data. I don't, but I suspect that they have some useful information we can learn from.
That's it's a really important point, Dr. Kreider, about the need for coordination of care and the importance of coordination in improving outcomes. The fee-for-service Medicare data does fortunately include patients who are enrolled in ACOs, but does not include Medicare Advantage, and also does not include patients, non-Medicare patients, commercial and Medicaid, and that's certainly an area for further work. Certainly, these issues do not solely apply to Medicare patients.
Thank you very much, Sarah. Thank you. Any other comments from fellow commissioners? Okay, should we turn to the impact of COVID-19 on market reviews? Because COVID-19 just has to affect everything that we do, so.
Great. Thank you, Professor Carl. I'll tee this up quickly. We're in between two research presentations. We wanted to spend a moment talking about the HPC's important role in examining market changes and their impact on cost, quality, equity, and access, and how we've been spending the summer thinking about how the unprecedented impact of COVID-19 may require us to adapt and evolve this market examination work. And so wanted to engage this committee in a brief conversation today. We only have 2 slides on this topic, but really to get your input and feedback on how should we be thinking about potential market changes in light of COVID, what questions will be most relevant for you, commissioners, and for the public in light of what we anticipate to be a number of different market changes as a result of the unprecedented stress and impact of COVID-19 on the healthcare system. So with that, I think I'm turning it over to Kate Mills and to Megan Wolf, just on the 2 slides and for a little bit of conversation here.
Thank you, David, and good morning, commissioners. As we all know, the pandemic has disrupted the healthcare system and significantly impacted the finances and care delivery practices of providers, from large systems to independent physician practices, with an impact that likely varies based on providers' starting points vis-a-vis things like historic pricing, payer mix, and financial resources. Given immediate priorities to reorganize care delivery, both to treat the sickest COVID patients and to help stop the spread of the virus, we understand that nationwide transactional activity slowed in the spring and summer. A number of experts are predicting, however, that beginning as early as this fall, merger and acquisition activity may pick up again. Transactions are expected to include those already underway prior to the pandemic, as well as those brought about either by financial hardship or a desire to innovate to respond to the challenges and opportunities brought about by the pandemic, including a need for many practices to quickly improve their remote capabilities and shift much of their care to telemedicine. Independent physician groups, large or small, that saw significant revenue losses this year may choose to become employed by systems or for-profit companies. Of the 6 notices of material change that we've received during the pandemic to date, one was a physician employment arrangement brought about in part to address the financial impact of the pandemic. South Shore's employment of anesthesiologists and certified registered nurse anesthetists practicing through South Shore Anesthesia Associates. Smaller hospitals or systems may also be acquired by larger systems with the financial and clinical resources to more successfully respond to a crisis of this magnitude. Per recent news stories, we may receive a filing soon for the acquisition of Harrington Hospital by the UMass system, which had been proposed prior to the pandemic. We may continue to see joint ventures between hospitals and other providers as hospitals consider strategic alignments and other strategies to reduce their operating costs and improve their efficiency. Of the 6 MCNs we've received since March, 4 have been joint ventures with community hospitals, and 3 have involved partnerships with Shields. We may also continue to see the integration of long-term care, post-acute care, and home health care into systems as baby boomers age and the need for these services continues to increase. Payers and providers may also consider innovative ways to share risk in this uncertain environment, including the potential expansion of primary care capitation to provide struggling physician practices with more stability. Next slide, please. While the broad focus of our transactional reviews remains the same, examining the cost, quality, and access impacts in the Commonwealth, we have been and will continue to examine these impacts and review the parties' specific plans within the context of the pandemic. For example, we are asking MCN parties whether the proposed transaction was driven or altered by the pandemic. We are also asking questions to discern whether the parties' plans primarily represent business as usual with the goal of maximizing fee-for-service revenue, or whether they are applying lessons and insights from the past 6 months, focusing, for example, on telehealth capacity and designing any new spaces with infection control and surge planning in mind. The pandemic has exacerbated inequities in the system for vulnerable populations and historically underserved communities, and further underscored the need for health equity as a core focus in all of the HPC's work. In our transactional reviews, we are broadening our examination of access impacts to include explicit inquiries about the demographics of patient populations that may be impacted by or left out of proposed transactions. We also anticipate that in this time of uncertainty and financial instability, healthcare entities will be particularly mindful of a transaction's impact on their operating costs and revenue. And where the parties plan to increase their revenue as a result of a transaction, we are examining the means by which they expect to increase their revenue and the impact this will have on care practice patterns and total healthcare spending in the Commonwealth. As David teed up, we wanted to show you these slides today to begin a conversation about market trends that you think are particularly important for the HPC to focus on in this new COVID reality, and any recommendations you may have for us on how to address COVID in our transactional reviews. And we welcome your thoughts.
Chris, I know this has been on your mind a lot. Do you want to start us off?
It's such a big subject. I'm aware of activities around the country where primary care groups are growing because hospitals are riffing senior docs. Those are hospitals that acquired those practices and frankly haven't done a very good job managing those practices, and so they're feel like they're losing money on those practices. The senior physicians have higher salaries, and the hospitals that are in the biggest trouble are basically offering early retirement to senior physicians. By the way, aren't providing jobs to the talented younger physicians coming right out of residency. So there is activity that I think probably portends some of the bigger moves ahead. Private equity is getting more active. They tended to be buying specialty groups rather than primary care groups. But the jury's out on whether independent practices will grow or contract. If we move to more and more capitation, they're likely to grow, as acknowledged on the previous slide. Capitation does provide stability for those practices. So it is going to be I think a very active 15, 18 months. And I think the landscape is really shifting. It's going to take a while for it to play out, but I think we are going to be seeing a lot in the next 3 to 6 months. The HPC, I think, is going to see a lot of requests for transactions. And I don't know, maybe I'm wrong, and maybe all those losses in Q2 get absorbed. But the general economic view is, and David, I ask you to comment back. There's going to be less money available for a premium in 2021, certainly from employers, and with reduced state tax revenues. So the squeeze is on, and we'll just have to try to get as close to it as we can as it evolves.
Yeah, just on that last point, the squeeze is definitely on. And the good news is that lots of people in Massachusetts will not become uninsured. The bad news is that many of the rates are going to fall. And the budgets at all levels of state and local government are going to be incredibly stretched, not to mention employer budgets and individual budgets and so on. The economy has recovered okay, but okay is still a long way from where it needs to be. So it's going to be a very, very rough current for a while.
David?
Yeah.
So just an observation that a lot of the notices we've received of late have been around ambulatory surgery centers. And I think when we review those, we really look at the cost implications and look at them and say, well, at an ambulatory setting, the cost is going to be less. But I'm wondering, to what extent do we look at what the impact is on volume, particularly where that surgery had taken place previously in a hospital, and what that does to overall capacity of those hospitals going forward. I know we've seen some situations where the result is less use, less volumes of the hospital. That could be good, but what does that mean for overall capacity moving forward?
Yeah. Don Berwick.
Thanks, David. I think, Megan, this may be embedded in what you presented, but one of the trends we're seeing is, of course, telehealth grew and telehealth companies grew. You know that one of the largest, Teladoc, acquired Livongo, which is a chronic care management telehealth environment. So we're seeing a kind of growth of actually a new sector of the industry. I don't know how these are financed. I assume maybe they're vendor contracts with mainstream providers, or maybe they enter the market as a separate provider. I should know that, but I don't. But these are structural changes that we ought to be tracking very closely. And of course, it relates to two other issues. One is pricing. Right now, we're still pretty much at what I'll call parity thinking, which is that telehealth visits are paid as if they were face-to-face, which I think will fall under a lot of scrutiny. And second is the what we've discussed before with David's David Auerbach's presentations at prior meetings. In the end, will telehealth be just put on top of a return to all the volume we used to have, but as an additional volume, or will it replace? And I don't think we know yet. David Cutler, I'm sure you're tracking that also closely.
We have been tracking that, and telehealth is coming back down as a share of visits. And I think even in absolute numbers, some are coming back to in-person visits. Whether they're going to be integrated in or added on top or whatever is, nobody's really figured that out.
Do you know, could a telehealth vendor enter the market as a provider on its own, licensed to give care without going through an existing Massachusetts licensed entity? And how would we deal with that if that's the case? I'm just not sure.
I do not know.
I know a little bit about this. Every state is different. And in Massachusetts, you have to have a network that involves licensed physicians in Massachusetts providing the care for at least for video services. And just on that point, Don, you're so right. The pricing question is paramount to, and maybe the Health Policy Commission can contribute to this discussion. It is impossible to imagine that telehealth visits can't be delivered at far less cost, because there is obviously far less overhead. Maybe we should have an update on the bills that are on Beacon Hill right now, the competing bills, to try to understand that better. I know David Auerbach presented that data. Paying close attention to it. But I continue to hear and am aware of entities where 70 or 80% of their cognitive care is being delivered still remotely and effectively. So in theory, it should, the less money available through tax revenue and by employers, which have less net income to spend, should be matched by an appropriate use of telemedicine, i.e., not churning patients, not seeing patients remotely more often than they need to be seen, but at a lower price. So this is a really interesting topic, and I hope we can stay on top of it over the next couple of months.
I just want, as a piece of information for the staff, I testified 2 days ago to a commission in Vermont that was exploring pricing and quality for telephone visits, what they call voice only now. So there's a whole frontier here, Chris. I agree with you. Like you thought.
Tim Foley, I'm going to give you the last word on this.
Oh, wow. Thank you. I mean, clearly, I think this is right to be prepared. And this, as we've all talked about, there's a lot of volatility in the healthcare market. I guess there's a lot of volatility everywhere based upon what we saw last night, whatever that was. And clearly, I think the election will have an impact on some of these transactions and all the issues that we've been talking about, the financing, health insurance, everything clearly. So I think a lot will depend on the outcome and where we go after that on the number of transactions, just as a point. And I just, one thing that I wrote down was about the vertical integration of long-term care, post-acute and home care. I think many of you know, I talk a lot about home care and nursing homes. Clearly, if we're looking at the impact of COVID, there's no bigger impact than it has been in our nursing homes. And I think there'll be a massive rethinking of that, and transactions or closures or integration has been mentioned. I guess my question on that specifically is what, based upon that presentation and that line around vertical integration, what role does the HPC or powers does the HPC have to be involved in any of those transactions? What information do we currently have that will inform understanding of them, and what do we need? I feel like many of the times I bring this up, we don't have a lot of that information, don't have the authority of that information. And I guess, if we're looking at how we're rethinking or potentially expanding the role of the HPC in a post-COVID world, it seems like this is a big area that we have not spent a lot of time. There's a lot of data presented on, which is really important. But I think we've learned that really so I guess, long-winded way of asking, what's our role there? Do we need expanded authority? Is there more information that we need to really understand what's going on, the ownership structures, the contracts that are signed, patients transitions, where they're going? I think it's a big open question that is having a big impact on many people's lives. And again, if we're looking at this through a post-COVID lens, it seems like a big area that we need to focus more attention and potentially need more authority to review and better understand.
So through our transactional review authority, we do receive transactions. For example, if a system were to acquire one of those post-acute care entities, as long as the system's net patient service revenue increased by 10 million or more, we would expect to receive a notice for it. And if there is a merger between a payer and one of those entities, as long as they meet the definition of a provider, which I think they likely would, we would also receive that as a notice.
So Tim, we do have some of that authority and have seen those transactions in the past. I think your point though is well taken, where they have been, I would say, a little bit few and far between over the last 8 years, and a great call for us to think more critically about what data resources we would need with perhaps more of those types of transactions, and perhaps a different lens by which we would be thinking about those transactions. So I think one piece of good news is that through the COVID pandemic, there have been some not insignificant investments in data collection and processing across the healthcare continuum. And I know that, for example, CHIA has now been collecting and improving a lot of the data and information around nursing homes. And so there could be new opportunities for us to see what data is there that we could bring to bear. But thank you for the comment.
Agreed. Thank you.
This is going to show up at our cost trends hearings as well. Sorry, I was trying to talk with mute on. So we have about 27 minutes on 2 topics, and we want to save the last 10 minutes or so to hear from the CHIA folks on hospital financial data, which I think is important that we hear about. David Seltz, I do want us to talk about opioid-related hospitalizations. I suppose the question is, can we do it in about 15 minutes or so, as opposed to the 30 minutes that we had ambitiously allocated ourselves for it?
I think it's worth presenting some of this information as a preview for the committee and for the public. It is very timely within the context of COVID. This is a work document that is still in progress at the HPC, so we are not publishing this chart pack today. And so I trust that Laura Nasuti, who's going to run through this presentation, can use her judgment to pick out the most important data points for us to discuss. I will turn it right over to her, other than to say this is another research topic which has a real nexus to COVID-19. I read this morning that more than 40 states have seen an increase in opioid-related deaths during this COVID-19 period. The information, the main part of this research that we'll present today is not data around the impact of COVID-19. This is data from largely from 2018. and is a reflection of a series of work. This is our third in a series where we every year annualize hospital data to understand opioid-related hospitalizations and ED visits. And that is one metric that we look at in trying to understand the overall arc and impact of the opioid epidemic. It is by far not the only one, and we'll of course defer to our colleagues at the Department of Public Health who track the epidemic with a whole range of metrics. But here we have carved out a particular focus on the impact of the epidemic on hospitalizations. And finally, we'll just say, proud to see here, as well as a serious illness and end-of-life care, focus on disparities for different patients. So with that, Laura, take it away, and you've got about 15 minutes, so thank you.
Okay, great. Thank you, David. Good morning, commissioners. Today, as David mentioned, I have a brief update on the opioid chart pack, but first I want to acknowledge that September is National Recovery Month, so can we move to the next slide? And so this month is a national observance to let the public know that substance use treatment and mental health services can help those with mental health and substance use disorders live healthy and full lives. So this is a timely presentation in that sense. As a little bit of background, we in Massachusetts continue to experience high rates of opioid-related injury and death. The most recent DPH opioid overdose deaths data brief shows a 6% decrease in deaths from 2016 to 2019. We have been seeing a moderating trend in the data that we currently have access to, but as David mentioned, the impacts of the COVID-19 pandemic on the opioid epidemic are unknown, although there is some emerging research suggesting that it may increase opioid-related injuries and death, especially among populations that are heavily impacted by COVID-19. So these impacts may include social isolation, economic insecurity, and just the trauma of the pandemic. And the findings here are selections from what will be presented in the chart pack, but next slide. Before we get into the data, I wanted to talk a little bit about how COVID-19 has, despite having an potential impact on increasing initiation of substance use or resumed use due to some of the impacts, the factors that I mentioned before, and despite some barriers to accessing in-person treatment, especially at the beginning of the pandemic, there are some opportunities through this pandemic for increased treatment. We were just talking about the expanding role of telemedicine and telemedicine payment parity. This includes the initiation of buprenorphine prescribing via telehealth. There has been an easing of restrictions on this dispensing of methadone. So now methadone, upon a provider's discretion, can be take home for up to 28 days. And there has been research showing that take home methadone dosing helps increase adherence and reduces hospitalization. And finally, for the healthcare workforce view, we've had some additional providers be able to administer or prescribe medication potentially. So pharmacists are allowed to administer methadone and buprenorphine. This was done on a DPH order, potentially in response to nurse shortages at opioid treatment facilities and acute treatment settings. And then there is also expanded scope for nurse practitioners to prescribe independently. They still have to do the 24-hour SAMHSA training and get that waiver, but because they can independently prescribe, there may be more opportunity. So these are spaces we can watch. But going into the findings, next slide. This slide may look familiar. It's very similar to a slide we showed last year at the release of the opioid chart pack. Unfortunately, like last year, we are still the highest for emergency department visits in the US among states that report this data. You will note this is 2017 data. Last year we reported on 2016 data, and that is because that is what is available for multiple states to do this comparison. However, moving forward in the presentation, we will have be looking at 2018 data. As for inpatient discharges, you can see that we're second highest. We inched up slightly from the 2016 data where we were actually third. Next slide. So all the opioid-related hospitalization data presented from here on out is from our acute care hospitals here in the Commonwealth through the CHIA's case mix databases. And on this slide, we're looking at both emergency department visits and inpatient stays. And we saw a slight decrease of 2.1% over this time period. That decrease was really 2016 to 2017. 2017 to 2018 remained flat. The dark blue is opioid primary diagnoses, and the light blue represents opioid secondary diagnoses, where the patient has the visit or stay, and the opioid diagnosis is only found as a secondary diagnosis, not the primary reason for the visit. And we'll talk about that a little more. Next slide, we'll break down emergency department visits from inpatient stays. So here we see that even though we saw only a 2.1% decline over this time period, actually, when we just look at emergency department visits, these declined by 8%, and this is primarily driven by those primary diagnoses. However, the inpatient tells a different story. So if we go to the next slide, we see that opioid-related acute inpatient hospital stays actually increased during this time period by 5%. And this increase was driven by increases in secondary admissions. So as part of this research, we wanted to understand what are the primary reasons that people are having these inpatient stays. So if we go to the next slide, we actually use the ARCS clinical classification software, which allows us to group a bunch of diagnoses codes together into like buckets to understand why people, who these patients are who are coming into the hospital with opioid secondary related diagnoses. And the number one you can see at the top is for mood disorders. In fact, 18% of all the primary diagnoses for patients with a secondary opioid related diagnosis were related to other behavioral health diagnoses other than opioid. So that includes alcohol related disorders and other substance use disorders. Bacterial infection and skin and subcutaneous tissue infections, which are 2 and 3, could also be closely related to opioid use disorder. Next slide. So those past 2 slides had just focused on inpatient, but now we're stepping back and looking at both inpatient stays and emergency department visits combined for several of the following slides. So even though we saw this decrease in opioid-related hospitalizations from 2016 to 2018, this did not occur uniformly across the state. This map is showing in the light blue to the dark blue increasing admissions per 100,000 residents, and then on top of that, there are bars that are in orange or yellow that are showing increases or decreases in this rate from 2016 to 2018. So here we can see that the Cape and Islands rate from 2016 to 2018 was 20% less, whereas in the Berkshires and Fall River, we actually saw an increase in their opioid-related hospitalization rate during this time period. Next. This is also an update from last year's chart pack where we examined the role of income. We don't have person level income in this database, but we do have community level income from census data. So we separated out the population by their community income, and to the left we have the lower income households or patients, and to the right we have the higher income. And again, we see this increasing disparity in lower income communities, where they're actually increasing their rate of opioid-related hospital discharges, whereas the other income quartiles increase slightly or stay relatively flat. The lowest income quartile here represents 41% of all opioid-related discharges, despite only representing 25% of the population, whereas the highest community income quartile, that's quartile 4, actually only represents 11% of opioid-related discharges, despite representing 25% of the population. Next slide. Again, we're looking at emergency department stays and inpatient emergency department visits and inpatient stays. One of the great things about the case mix database is it does have really well populated and useful information on race and ethnicity, and it allows us to do this deeper dive to understand the trends that we are seeing among different populations. And here, unfortunately, we see increasing disparity, especially for Hispanic or Latinx men and Black men as compared to white men, where we see Hispanic and Black men increasing the opioid-related hospital discharges by 6 and 8%, while white men saw a decrease. Among females, we see a slight decrease among white women, while Black or Hispanic and Latinx women remain either slightly increased or moderating to flat. There's a little variability there. And I would also like to note that the reason we are not including other racial ethnic groups in this slide is just due to small numbers, not because the opioid use disorder may not be in those populations. Next slide. As I mentioned, the focus of this chart pack is really on acute care hospitalization. So of course we want to look at where these hospitalizations are occurring, and the chart pack will have several different slides with different hospital views. However, we pulled this one out for today just to give a sense of how important or how significant these opioid-related discharges are, in the world of inpatient stays. So we actually have 19 Massachusetts acute care hospital campuses having over 5% of their inpatient stays with an opioid-related diagnosis. And you can see here, Berkshire Medical Center is up at 13% of all their inpatient stays have an opioid-related diagnosis, either primary or secondary. And with that, I can go to my concluding points. Take a breath. So as I mentioned, we saw the hospital utilization declining slightly, but that decline was not uniform across the state. Inpatient hospitalizations increased, and this was primarily driven by secondary opioid-related diagnoses. And that these inpatient stays represented a significant amount of inpatient volume in the Commonwealth. The 2018 data show increasing disparities for Hispanic and Black men compared to white men. And one of the limitations of this data is it's unclear if this is due to new initiation, lack of access to community-based treatment. Again, we're only looking at acute care hospitals in this data, so that is a very small segment of this treatment world, or other causes. And residents of lower income communities in Massachusetts have a disproportionately higher rate of opioid-related hospitalizations. So with that, I'm going to stop and open it up for questions. That was my drive-by.
That was quite impressive, Laura. Laura, is there any way, do we have any informal evidence about what's happening in 2020?
Not at this time. There was one small study that I read out of a hospital emergency department in Virginia that saw an increase in disproportionate increase in Black patients coming in for opioid overdose or opioid use related ED visits. I know that DPH's next opioid overdose report is going to be released sometime in November, but I'm not sure that their data gets that far into 2020. I'm not actually sure about the time frame of that report.
Don?
Yes, this is for the parking lot, David. Just so I don't forget, I just finished service on a National Academy of Medicine committee on decarceration in the COVID epidemic, dealing with people in jails and prisons, both who are there and returning. This pattern of opioid needs is really dramatic in that population, and I wonder if the HPC might at some point consider a look at people who are incarcerated and returning from incarceration with respect to the needs that Laura's been talking about. I may be out of bounds, but thought I'd mention it.
Thank you. David Seltz, it sounds like we should turn to hearing about hospital finances.
Great. And thank you, Laura, for moving through that. You did a wonderful job. That was really great. So look forward to the release of that chart pack soon, and we'll announce that. Thank you. We're pleased to be joined for the last few minutes of today's meeting of this committee by our colleagues from the Center for Health Information and Analysis, who I've asked to join us today to give a brief presentation on some of the hospital financial data that they've been collecting. Obviously, this has been a source of interest for the HPC and for commissioners to understand the impact of COVID-19 on financing of all parts of the healthcare system. And so wanted to provide this latest information, which I thought was really quite excellent from our sister agency. So thank you, Liz, for being here, and I will turn it over to you.
Great. Thank you, David. And thank you guys for having me today. Can head right on to the next slide, no problem. Great. So just by way of background, CHIA collects on a quarterly basis financial statement information from all of the acute care hospitals in the state, as well as their associated hospital health systems or parent organizations, and the affiliated physician orgs as well. And those financial statements are required to come in 45 days after quarter end, and we typically put out a report 45 days following that. Because of the times we are in and everything going on with COVID, we wanted to take a much more timely look at the data. So we worked with the hospitals and we worked with some of the stakeholders, and we implemented a voluntary monthly financial filing that began starting with March 2020. So because this was voluntary and it was an additional burden, we tried to take a little bit of a smaller look at the data. So this is collecting statement of operations data, which is just really their revenues, their expenses, and then the corresponding profit or loss. And in a much quicker turnaround, this data is due approximately 30 days after month end. So we were able to get a quicker look at how the COVID pandemic affected the hospitals. And then one thing that was very important, it was something that was brought to our attention, was that within this statement of operations that we collected, we isolated the COVID relief funds that the hospitals received. And these are typically really the supplementary funds that came as part of the CARES Act or through the state in what was approved, so that we were able to look at how the hospitals were doing if those funds had not been approved and distributed, as well as what it actually looked like during those months, including those. And we included those as operating revenue in all of our analysis. So the first report that we put out was in August, and it included the first 3 months of the pandemic, so March, April, and May. 38 of the 61 hospitals participated voluntarily, and those hospitals actually represented almost 3/4 of the operating revenues for acute hospitals in the state. So it gave us a significant picture of how the hospitals were doing. Next slide, please. So this is a quick look that really graphs how each of the hospitals reported their total margins or profitability to us. And we had created a base period using the quarterly data we already had, which we sort of are calling pre-COVID or pre-pandemic data, which is data through December 31st, 2019. And as you can see in March, the profitability and declined significantly across all of the hospitals that reported to us. 34 of the 36 hospitals reported losses in March, and things improved slightly in April and May due again to those COVID supplementary funds that were received. But overall, most of the hospitals continued to report losses in both April and May. Next slide, please. And this is just the same idea, but a different look as it groups the hospitals based on the different groupings. So the academic medical centers, the teaching hospitals, community hospitals, and then the high public payer hospitals. And you'll see in the base period, the participating hospitals had a median of 3.4%, which is pretty typical for the hospitals in the state. That dropped all the way down to nearly negative 30% in March. And again, the median margin started to go up a little bit in April and May, but that was really due to the COVID funds that were received. And again, most remained negative overall in March, April, and May. Next slide, please. So this was something.
Can I just jump in with a question?
Absolutely.
Do you keep data on cash on hand?
We do, and that is part of our quarterly filing. So we get balance sheet data in our quarterly filings. We chose to only go with the statement of operations because we didn't want to add to too much of a burden. So the quarterly filing that's actually due today will have that information, and that will be for data through June 30th.
Can you, when you prepare that, can you make sure to send that to David Seltz, who can pass it on to us?
Absolutely.
I'm sort of curious about what's been the trend in days cash on hand.
Absolutely.
Thank you.
So this graph here really just shows what the difference would have been had all of those federal and state funds not been approved and distributed to the hospitals. So the lighter blue blocks at the top show what we consider their actual margins with all of those funds. The dark blue, which again, as you'll see, clearly are much worse margins, would have been had they not received any of that funding, how their profitability actually would have looked in the months of April and May. And across the board, across all statewide and by each cohort, you'll see that those funds did a lot to help supplement the profitability and the margins that they had. Next slide, please. And then this is just one more look, which we thought, of course, goes a little beyond just profitability and looks at the trends between operating revenue and expenses across the hospitals. So something just large to note is that navy blue block at the bottom is their net patient service revenue, so their main revenue from operations. And as you can see in March, April, and May, it's all significantly lower than the base period, as we would expect, because operations were impacted severely by this. And in particular in April, which was the first full month that all hospitals were impacted by COVID. And in aggregate, and something just important to look at, is that gray dot represents expenses. And as you'll see, even with the supplementary funds, which are those light blue box at the top, it wasn't enough to actually be more than the total expenses in aggregate.
Do we have, maybe you already showed this, I may have missed it, how the federal relief funds were distributed across type of hospital?
I could share that in a brief sort of, I didn't have it on here. Generally speaking, at least in these couple months, the academic medical centers, the largest hospitals, received the bulk of the funding. And it was really based on how the federal funds were set out. They were paid primarily based on first Medicare fee-for-service revenues, a percentage of the total nationwide, and then a percentage of net patient service revenues. So as you would imagine, the largest hospitals ended up with a larger share of the payments that went out. And then beyond that, there were high impact payments in May, which was based on how many COVID patients the hospitals had reported to HHS and sent back out. So Massachusetts, I believe, received about 500 million total from the high impact payments also. And a lot of those went to the larger hospitals as well.
Perhaps in follow-up, I'd love to see the detail if that's easy to do. If it's hard to do, don't bother, but I'd like to see it.
Absolutely. And in our report itself, there is a data table at the end that shows by hospital and system the amount of COVID funding they received per month. So it's broken down into March, April, and May. So we can share that report for sure.
Thank you.
And then just one last, and I'll try to wrap up quick. This is just a quick graph of how operating revenue and expenses were impacted. And we really just wanted to scale it on the same scale. So you could see that while operating revenue declined significantly, expenses did not decline at the same rate. And then last slide. So just a quick next step so that you're all aware, we are working on our next report, which is going to now include June and July data. We hope to publish in the next 2 weeks. And then to the earlier point regarding sort of days cash in hand and balance sheet information, we're receiving the next quarterly filings for the fiscal year-to-date period that ends June 30th today. And that report's expected in November. It was also expanded to get a lot more information on the COVID relief funds. So that should also include things like accelerated payments, advanced payments, loans, and things of that nature. And the one other thing just to sort of keep in mind is that all of our monthly is it's standalone data. So it's how they're doing in that month alone. It doesn't necessarily give the greater picture of how they're doing overall. And the quarterly report will do that. It will look at how this impacted the grand scheme of their fiscal year. I'll take any questions if there are any.
Thank you. Tim, do you want to start us off? And we'll try and be brief because I know that we.
I understand we got to go, right. And maybe it was answered when you talked about doing the advanced payments for the Medicare side. Do we have information of how much, if any, had to be paid back at this point, or the potential of the hospitals having to pay that back because they did not meet the discharge or the patient volume for the Medicare payments, the advanced Medicare payments? Do we have that? Will we have the next report to get a better, fuller picture of the finances? I know a lot of that has to be potentially paid back, and not too sure where that stands at the moment.
That actually is part of our expanded filing that's coming in. So we had asked as part of that what they received for revenue, where they recorded it so that we can understand better if it's a balance sheet information or a statement of operations, P&L information, and then how much they expect to pay back. And some of that might be estimated at this time. So we're hoping to get a much fuller picture from this information.
Thank you.
Certainly going to be incredibly important information for lots of parties. Any other final comments before I close this particular committee meeting? Thank you to everyone. And why don't we adjourn, but I'm going to turn it over right directly to Barbara, who's going to take over the other committee meeting.
Barbara, I think you're just on mute here. Sorry.
I was being so complimentary to David.
No need to repeat that.
Okay. So as you can see, without any glitches whatsoever, we are transferring to the meeting of the Care Delivery and Transformation Committee. This is the second meeting of the double header here today at the Commission. We have a very intense agenda. We have some very interesting and exciting things to talk about. But before we get that, first of all, I want to welcome the commissioners who are joining us at this meeting, for this meeting, and would move directly into asking if there are any additions or changes to the minutes, and also point out and remind everyone that because we are on Zoom, the approval of the minutes will need to be a verbal approval. So are there any additions or changes or questions to the minutes? Hearing none, then I think we're ready for a roll call.
Okay, we'll start with you, Madam Chair. Commissioner Blakeney,
Aye.
Commissioner Berwick,
Aye.
Commissioner Cohen,
Aye.
Commissioner Peters,
Aye.
and is Commissioner Kreider still on the call?
Yeah, I'm here. Yes.
Great. Thank you so much. It's unanimous. Thank you.
Perfect, thank you. We have three components to our meeting this morning, and we're going to start it off with the ACO certification program design. There are some additional new components that we want to talk about, and I'm going to turn the meeting over to Kelly.
Thank you so much, Commissioner Blakeney. Could we please advance the slide? Okay, so as we get into our ACO topic today, just to provide a little bit of context and reminder, as you know, this is the process by which we establish payer-agnostic standards that characterize accountable care organizations, collect data to ensure, to determine ACO's performance against those standards, and ultimately certify the ACOs. As always, we try to strike the balance between using this program to consistently raise the bar for what it means to be an ACO in the Commonwealth, while also providing flexibility that both recognizes the diversity of the ACOs that we certify and recognizes, legitimate concerns about reporting burden. And finally, in addition to that, we're consistently focused on capturing learning and experience that can help advance the entire field. So with that context, let me introduce my colleagues, Mike Stanek and Catherine Harrison, who will provide an update on the design of the next version of ACO certification and propose next steps in advancing this work.
Thank you, Kelly. Good morning, commissioners. I'm here today to provide an update on our proposed changes to the HBC's ACO certification program. But first, a few words of introduction. The launch of the ACO certification program back in 2017 made Massachusetts the first state to have statewide all-payer standards for care delivery, as well as transparent, publicly available information about how ACOs are structured and operating today. To that end, we've published profiles of each HBC certified ACO, and through a webinar, a series of policy briefs, and upcoming data points, we've documented ACO characteristics, their strategies and activities for managing population health, and the nature of the risk-based contracts they hold with payers. We have certified 17 ACOs that collectively have nearly 3 million Massachusetts residents attributed to them. We're excited to build on that success and continue to support transparency and learning across the health system in Massachusetts. Next slide, please. As we look toward our third certification cycle for ACOs, we are proposing some changes to the certification standards. This slide provides a snapshot of where we are in the development process for updating those standards. The ACO certification program standards have largely remained unchanged during the first two certification cycles. Now, as the program is becoming more mature and we've had the opportunity to learn lessons through two certification cycles, we've been working this year to propose refinements to the standards that we believe will even better facilitate care delivery transformation in the Commonwealth. So far, we've done a bit of informal stakeholder engagement to get some early input on the draft requirements that we're putting in front of the committee today. Next month, we intend to provide a formal comment opportunity to the public. We are looking forward to gathering input from the many stakeholders in the Commonwealth with an interest in this program. After that public comment process, we will return to the full HBC board for approval of new standards. The new standards would be in place for ACO applications submitted in the fall of 2021. That is to say, they will apply to ACO certifications effective 2022 to 2023, since these are two-year certifications. Next slide, please. Before we look at the new proposed standards, I wanted to provide a reminder of the certification criteria that are in place today. As we've said before, we seek to promote continued transformation in care delivery while ensuring that certification is within reach of provider organizations of varying sizes, experience, organizational models, infrastructure and technical capabilities, populations served, and locations. Our goal with these standards has been to encourage value-based care delivery and promote investments by all payers in high quality and cost-effective care across the continuum. ACOs applying for certification must attest to certain prerequisites listed here. They must also provide some information on risk contracts and quality performance under them as background information. The evaluative portion of the application requires that ACOs satisfy 5 assessment criteria. The assessment criteria focus on patient-centered accountable governance, leadership-driven performance improvement activities, population health management programs, and the availability of cross-continuum care. Finally, ACOs have been required to provide supplemental information on 3 topics, which you can see listed here. Next slide, please. As we approach updating the certification criteria, a few principles have guided our thinking. These are very much informed by our experience in the first 2 certification cycles. The first is the recognition that we are all still learning. The national evidence on what works for ACOs is still mixed, but ACOs do seem to perform better on cost and quality metrics with time and experience. Effectively and sustainably slowing cost growth and improving quality is challenging. The ACOs, the HBC, and the policy community more generally are still learning how to do it. To that end, we would like to provide flexibility to the ACOs in recognition of the fact there may be different ways to document how the ACO meets the spirit and the letter of our standards. As we will discuss later in the presentation, that is why we are contemplating providing a menu of options for documenting adherence to the standards. The third principle here reflects a slight shift in emphasis for the criteria. Given the diversity we have found among ACO approaches over the past few years, it occurs to us that the degree to which an ACO is positioned to build on and learn from its activities may ultimately be most important. Thus far, we have focused on recognizing definitional attributes or capabilities of ACOs and creating a baseline understanding of ACOs for both the HBC and the public. In our proposed standards, we embrace the ACO model as a catalyst for learning and improvement among healthcare organizations. In this, we were influenced by the Institute of Medicine vision of a learning health system, which they have described as one in which science, informatics, incentives, and culture are aligned for continuous improvement and innovation, with best practices seamlessly embedded in the care process, patients and families active participants in all elements, and new knowledge captured as an integral byproduct of the care experience. And finally, we are mindful of the role ACOs can play in advancing health equity in the Commonwealth. And we have put some thought into how the certification standards can focus attention on improvements in this area. We'll return to this a little later in the presentation. Next slide, please. Here, Commissioners, you can see an overview of our proposed updates to the certification requirements. As we have in the past, we would collect some prerequisite or background information, this time on basic definitional ACO attributes that are true of any ACOs, governance structure, risk contracts, and quality performance under them, and attestations of compliance with relevant requirements. Then, as with our current standards, HBC certified ACOs would demonstrate an additional layer of functionalities or competencies. The evaluative portion of the application would focus on 5 assessment criteria. The revised criteria, conceptualizing ACOs as engines of a learning health system, emphasize collecting and using information and data to implement and iterate on strategies for delivering high-value, evidence-based, patient-centered care. We will discuss these criteria in greater detail in a moment. And then we would continue to collect information on supplemental information domains. We'd stick with 3 to 4 as we did in the last certification cycle to minimize the administrative burden on the ACOs. So let me pause here before we delve into the assessment criteria in more detail and see if there's any questions from the commissioners at this point.
Don?
Mike, thank you. Terrific presentation, by the way. On the assessment criteria, perhaps you're getting to this, does that include the capacity to know equity within the ACO?
So we'll dive into this in a little more detail, but the equity component of the criteria really focuses on the ability to gather data and stratify it by race, ethnicity, and other factors to really guide the way ACOs manage their populations.
Thank you.
Are there other questions? I think we're good to go on, Mike.
Great. Next slide, please. So we'll focus in this section just on the assessment criteria, and I'll give a quick overview of each proposed criterion as we go. As a general note, the language on these slides represents a simplified or abridged version of the proposed language for each criterion. The full proposed language for the standards is available in the appendix to these slides, but here we just wanted to convey the concepts at a high level. The first criterion focuses on ACO capacity for collecting and using information from patients to improve and deliver patient-centered care. ACOs would choose from a defined menu of potential documentation options and provide one piece of documentation to demonstrate how the ACO's leadership monitors patient experience or preferences, and one piece of documentation to demonstrate how the ACO uses that information to improve the patient experience. You can see in these boxes, we've included potential items from the menus of documentation options that we would provide to the ACOs. And this is one of the two standards that would include a requirement that data be stratified by race, ethnicity, or socioeconomic factors to facilitate the ACO using an equity lens in its program development. And I'll have a little bit more to say about our approach to incorporating health equity considerations a little later on. Next slide, please. The second criterion recognizes the importance of culture to ACO performance. Here we focus on the ACO fostering a culture of continuous improvement, innovation, and learning to improve the patient experience and the value of care delivery. We contemplate a variety of different ways an ACO may be fostering such a culture, from citizenship activities to internal financial incentives. And we would ask the ACOs to demonstrate 2 from this list. Next slide, please. So having contemplated the leadership role in driving an ACO-wide culture of performance improvement, here we turn to ways the ACO supports frontline clinicians to decrease unwarranted variations in care delivery and increase adherence to evidence-based guidelines. This criterion focuses on the ACO commitment to using the best available data and evidence to guide and support improved clinical decision-making. You can see here we would require 1 piece of documentation, again selected from a menu of options, demonstrating that the ACO is facilitating processes or tools to deliver current clinical knowledge to the point of care, and 1 piece of documentation demonstrating that providers are receiving actionable data, either on their own performance or on their patient panels. Next slide, please. This next criterion is very similar to an existing assessment criterion. It requires that the ACO develop, implement, and refine programs and care delivery innovations to coordinate care, manage health conditions, and improve the health of its patient population. Here we're looking to see some documentation of how the ACO stratifies or screens its patients to understand their need for population health management programs. And then we're looking to collect some information about those programs themselves, with a particular emphasis on the priorities, goals, and performance targets the ACO uses to assess and refine those programs over time. This is the second standard where we propose to include a requirement that data be stratified by race, ethnicity, or socioeconomic factors. Next slide, please. The ACO certification program has been grounded in the belief that the healthcare delivery system should improve health by delivering coordinated patient-centered healthcare that accounts for patients' behavioral health, social, and medical needs. This criterion requires that the ACO recognize the importance of non-medical factors to overall health outcomes and cost of care. In particular, it requires that ACOs seek to integrate behavioral health and connections to health-related social supports into their care delivery models. Here we would be looking for information on the milestones and implementation targets the ACO is holding itself to in implementing a behavioral health integration strategy. Or if there is no ACO-wide strategy, we would be looking for documentation of an advanced integration initiative or pilot within the ACO. Similarly, we would be collecting information on the incorporation of screening and referral processes for health-related social needs into care delivery. Next slide, please. So I mentioned we have had some informal discussions with stakeholders to get some preliminary feedback on this framework and these proposed criteria. These conversations were very helpful. We generally heard support for providing flexibility via documentation options for ACOs, and there was general agreement that we are hitting on the right topics and areas. There was also substantial interest in greater transparency on the information we are collecting to ensure that it's being put to productive use. The folks we spoke with also requested that we work to minimize the application burden. And finally, the topic of COVID-19 did come up. Stakeholders reminded us to take the disruptions to provider operations in 2020 into account when we evaluate application materials next year. So there's a few more slides, but this is the end of the criteria section. So let me pause here and see if there's any questions from the commissioners at this point.
Not a question so much as just an observation. A great presentation, Mike. And I think as someone who's watched the development of this from day one, I think this really does reflect sort of the next generation of thinking around the certification process. I guess my only question is, do we think we can expand the applicability of these standards to more than the 17 Medicaid ACOs?
That's a good question, Commissioner. I think potentially. The 17 ACOs that are currently certified, I think, represent a large portion of the delivery system in Massachusetts. But to your point, the point of these is to make this accessible to ACOs all over the Commonwealth. So if there are some that are currently not certified, we would absolutely be interested in trying to get them to a place where they could achieve certification.
It appears, please, Don, go ahead.
Yeah, thanks, Barbara. Sorry to interrupt. I just am so pleased to see the learning health system stuff get really represented here. You've taken it very seriously in a way that I haven't seen anywhere before. It's terrific, Mike. Thank you very much.
Thank you.
I think it's clear we're moving into a very cutting edge approach here, and I think it's welcome. Okay, I think if there are no other questions.
Okay, so next slide.
Yep.
So we'll continue to collect supplemental information as part of the ACO applications. We generally use the SI questions as an opportunity to gather structured data. That information is important both for shedding light on ACO innovations and practices, as well as for informing future modifications to the certification standards. Our thinking right now is that next year we will ask questions in 3 domains: activities ACOs are engaging in to promote health equity, innovative care models that ACOs are deploying, and the strategies that they are implementing to control TME growth. Next slide. So given the HBC's Health Equity Action Plan, we've given some thought as to how best to embed health equity principles into the ACO certification program. Our sense is that the best place to push on this right now is with respect to data collection and analysis, ensuring ACOs have the capability to stratify some of their data by race, ethnicity, or socioeconomic factors, and are poised to consider inequities across those lines when formulating programs and strategy. Similarly, we aim to use some of our supplemental information collection to understand ACO priorities and current activities with respect to advancing health equity. We're also contemplating ways we may be able to assist ACOs to accomplish improvements in health equity via things like technical assistance or targeted investments in the future. This would be a part of what we hope would eventually be a broader array of opportunities that the HBC can make available to certified ACOs, our part in supporting learning and delivery system transformation in the Commonwealth. We think that would be an exciting prospect for certified ACOs. Next slide, please. So I'll conclude here with a few questions for you, commissioners, to get the discussion going. First, does this learning health system framework make sense as the focus of our next cycle of certification? Second, are we capturing the right topics? Is there anything that's obviously missing from these proposed criteria? And finally, is the HBC's commitment to applying a health equity lens appropriately represented in these proposed criteria? I'll open the floor to discussion.
Chris?
Yeah, thanks, Barbara. Mike, this is great. I feel like I have a better and better understanding of the certification process, but I am missing, or I have forgotten, and need help with better understanding the payment models and how they may or may not vary among 17 ACOs. Could you give a little thumbnail right now on sort of the general attributes of the payment model? And my hope is that at the next presentation we can have a presentation of a more detailed view of those payment models. Once again, mindful of a comment that Megan made earlier, that there is a general understanding in the primary care community that capitation provides stability. So can you give me a general refresh on the payment models?
Sure, yeah, I can speak to that at a high level. So we do collect some information about the payment models that are being used in risk contracts as part of the background information about those contracts that we are collecting. The vast majority are using sort of a Medicare-like model of fee-for-service with a risk target with upside and downside risk. Downside risk is very prevalent here in Massachusetts. The overwhelming majority of contracts do have some downside risk in them. But in general, it's still fee-for-service with a budget that that the ACOs are being measured against. Capitation is still pretty rare from what we've seen.
So I think, and they do vary, right, across the
The
board.
parameters vary quite a bit. We a lot of that information is proprietary, and if we were going to summarize it, it'd be a very high level. That is protected under the statute. But they do vary in the parameters of how much risk sharing and if there are caps on risk and things like that. There's quite a bit of variety in the market.
I will just add, as part of our work to share learnings from this program, we actually did create a brief in the last certification cycle on risk management and the payer contracts for the ACOs. So that includes, I was just looking it up, there are 85 risk contracts among our certified ACOs, of which only 26 are upside only. And so there's a lot more in that brief, Commissioner Kreider. And so sounds like a great opportunity to revisit some of that data and information.
Thank you, David. Any other questions or discussions? Mike's asked us to weigh in on 3 questions. Why don't we take a moment to do them in turn? So are we hitting the framework, or is this making sense? Are we missing anything?
I think we are. I think this is great. One of the indices I'd be looking for if we want to push the envelope a bit is exchange among ACOs about what they're learning, so that the learning systems is just within an ACO, it's among the whole fleet of them. And the more of that, the better.
I would agree with Don. I would also say to also learning with their community partners.
Picking up on the community partner frame, what do we know about that partnership as it relates to the certification? How active is it? How engaged is it? How meaningful is it?
So I would say most of that is on the Medicaid side of the ACOs at this point. The Community Partner Program is part of the Mass Health ACO program. And I believe they put out some materials kind of summarizing the extent of those partnerships, who's partnering with whom. And at this point, I would say we're not directly collecting a lot of information about those community partners. We have, in the current certification cycle, asked about, as part of our cross-continuum care criterion, we have asked which partnerships exist, so we know the relationships that are there. But beyond that, we haven't really been able to delve below the surface yet.
Okay. I would encourage that as we start to look at the next iteration, that we keep in mind the importance of those partnerships, and that we somehow invite those partnership frameworks more directly into our next steps. It's critical that the partnerships are meaningful. Any other thoughts about our framework making sense? Okay, are we capturing the right topics? Are we obviously or is there a big gap here someplace? I think the silence suggests that nothing comes to mind, David.
Barbara, I can add
yes.
something, just to break the silence. The ACO form of coordinated care has a lot of cousins around the world, and there is a pretty edgy idea here that the ACO community could be looking very broadly for examples of how to integrate care the way they want to. And I just learned so much from global references. I might add that to the pot. There's a tremendous amount of work going on integrated care outside the US that's very informative.
Don, how would you think about inviting that knowledge into us, into our system? What might we do to encourage that?
Well, well, let's start with HPC. If the HPC has mechanisms, learning mechanisms, which I would encourage, and we've done quite a bit about it, I think we could take that a step further. There are colleagues who I could imagine workshops for ACOs on helping connect to global examples, which the HPC could help. You're right. It's sometimes hard to find those examples, but I think it's quite doable. Apologize for that.
Okay. Well, let's keep that opportunity in mind, and let's think in the future of how we might structure create more of a framework to encourage and engage in that. Okay, thank you, Don. What about the health equity lens? This is a new focus that we're just starting to institutionalize. How do we bring that in? How do we make sure it's well represented?
Barbara, I'm wondering, I think Mike captured where in looking at the patient population, they're trying to apply the equity lens. But I'm wondering if there's an opportunity also to apply it on the practitioner side, who's providing the service. And I'm also thinking, particularly community health workers and others, to what extent we're seeing people of color represented in the workforce of in the network of the ACOs.
Interesting points. Mike?
I was just going to, I'm sorry.
Go ahead, Lauren. Please,
I was just going to interject that Mass Health is also sort of undergoing the development of a health equity strategy with respect to ACOs as well. So I think that what you've put forward here makes a lot of sense and would just encourage the coordination so that we are sort of setting the same set of expectations, both on the certification side, but from Mass Health on the payment programmatic side.
Excellent suggestion, Lauren. Thank you. David Seltz, is there a way to think about making that partnership?
Yes, that is a hallmark of this program is the partnership with Mass Health, and we've had the opportunity to present this initial framework to them and got a lot of really positive feedback. So as we go through our public comment period process and look to finalize these standards, I think in early 2021, I think the timelines will align that we'll be able to work really closely with Mass Health to have a really coordinated strategy around health equity. So I think that's a great positive opportunity for this program.
That sounds like I agree, that sounds like a great opportunity. I would encourage and I hope that as we look at doing this work, that we make sure that we engage the population base that we're trying to create equity for. How do we do that? How do we bring the individuals who have been disenfranchised, the populations who have been disenfranchised, into this conversation in a meaningful way? I keep going back over and over and over again to nothing about me without me. How do we engage with that? And how do we make that a hallmark of our next steps in talking about health equity?
Thank you, Commissioner. I couldn't agree more, and we will take that on as a challenge for ourselves as well.
Great, thank you. Any other comments or suggestions for Mike to bring back to his team as they continue to look and refine this work? This is a great next step. I think it really pushes us forward in very meaningful ways. So let's continue to keep the energy under this. Any other?
Thank you, commissioners.
Okay, thank you very much, Mike. That's a lot of hard work. That's a lot of good work. Please extend our thanks to you and your team for putting that together. It's very, very well done and very much appreciated.
Thank you.
So Kelly, I'm going to come back to you because we are about to move into the Maternal Child Health Investment Program. And I think that there's a lot of good information to be shared. So Kelly?
Thank you so much, Commissioner. Just to provide some background to the attendees, in 2019,
Kelly, I think you've frozen.
I'll jump in here and we can advance to the next slide. Just by way of background for the commissioners, in 2019 state budget, the legislature included a special provision and mandate for the Health Policy Commission to develop and implement a pilot program really focused on maternal health. And this is the legislative language. I will not read the legislative language other than to note that with this mandate to develop and implement the program, there was also an appropriation of $500,000 to help fund this investment opportunity. And so what we would like to do today is to present to you the work that we've been doing to both educate ourselves on these issues and to understand how they impact residents in Massachusetts and to identify where we think there could be a real opportunity for positive impact, even with a relatively small amount of money that really meets the legislative intent and as well as consistent with the mission and of the Health Policy Commission. And would note at top, this is a program that is intended to be run in consultation, close consultation with the Department of Public Health and the Betsy Lehman Center. Next slide. Jasmine, were you planning to take over these slides at this point, or?
I can take over at this point. Thanks.
Okay,
David.
great. So very happy to introduce the member of our team who's really been leading a lot of this research work along with many others at the Health Policy Commission, but happy to introduce Jasmine to walk through our presentation.
Thank you, David. Good morning, commissioners. So starting on this slide here, the graph is from the CDC and highlights that the pregnancy-related mortality ratio in the United States has been increasing since at least 1987. The CDC has also found that 65.8% of pregnancy-related deaths between 2008 and 2017 were preventable. So we know that there's an opportunity for us to intervene and address this issue. Next slide, please. When we zoom into Massachusetts specifically, we see that maternal mortality in the Commonwealth is less common than in other states. Still, there are inequities by race and ethnicity that exist despite the low rate of pregnancy-related deaths. Between 1998 and 2013, Black non-Hispanic women had twice the rate of severe maternal morbidity as compared to white non-Hispanic women. Between 2000 and 2007, Black non-Hispanic women were twice as likely to experience pregnancy-associated death compared to white non-Hispanic women. Next slide, please. We've been engaging with various stakeholders on this topic for several months, all of whom you'll see listed on this slide, really to gather their thoughts and insights on the topic. We've met with our colleagues at our sister agencies like the Department of Public Health, Mass Health, and the Betsy Lehman Center, as well as several state representatives interested in this topic. We've also met with March for Moms, which is a national maternal health advocacy organization, and the Perinatal Neonatal Quality Improvement Network, who we've collaborated with in the past on our mother and infant focused neonatal abstinence program. We also met with Accompany Doula Care, Stewart Health Choice ACO, and the Birth Sisters program at Boston Medical Center to learn about their organization's doula care programming. Next slide. We've organized the themes from our stakeholder engagement on this slide into two categories: opportunities and potential value, and clinical and operational considerations. In this first category, we've expanded beyond the legislative language a bit to include pregnancy-associated deaths, which would include deaths related to behavioral health, and we've also expanded to include severe maternal morbidity. Again, this is all with an emphasis on addressing racial and ethnic inequities, particularly for Black birthing people. Stakeholders were enthusiastic about doula care as a model to reduce inequities in maternal health outcomes and emphasized the importance of investments in a diverse doula workforce that reflects the communities that the doulas would be serving. We also learned of opportunities to align with other efforts that are happening in this space when possible. In our second thematic category, clinical and operational considerations, we've highlighted that Black, Indigenous people of color continue to have negative experiences during hospital births. Stakeholders emphasize that programs should respect people's decisions regarding where and how they receive care to ensure these populations' agency in prenatal, labor and delivery, and postpartum care. We also heard that training and supporting a diverse doula workforce at a living wage can sometimes be difficult. Finally, we understand that it's important for us to clearly define the target population, especially as we are attempting to focus on racial and ethnic inequities. Next slide. We pulled together some data on the birthing landscape for Black birthing people in the Commonwealth. As of 2017, 1 in 10 births in Massachusetts occurred with a Black birthing person. 11 of the 30 largest municipalities in Massachusetts had percentages of Black births that were greater than 10.3%. 60% of births by Black people in 2000 occurred in 4 hospitals. This does signal that many Black birthing people are giving birth in a relatively concentrated geographic area. Most of these are in Boston proper. And about 8 hospitals in Massachusetts, to our knowledge, have formal doula programs or partnerships with doula organizations. Next slide, please. We're developing this investment program with the concept of birth justice as a guiding principle. So here you'll see this definition from Ancient Song Doula Services, Village Birth International, and Every Mother Counts, which are advocacy organizations and doula services providers. Birth justice is achieved when individuals are able to make informed decisions during pregnancy, childbirth, and postpartum that is free of racism, discrimination of gender identity, and implicit bias. Birth justice requires that individuals fully enjoy their human rights regarding reproductive and childbirth-related health decisions without fear of coercion, including coercion to submit to medical interventions, reprisal for refusal of care, or face the threat of inadequate medical care. Birth justice centers the intersectional and structural needs of individuals and communities. So this is a guiding principle that we're using moving forward with this work, given the importance of the racial and ethnic equity lens. Next slide, please. At this point, I've mentioned doulas a couple of times, so I'll take a moment to explain what doula care is, which is represented in the yellow bubbles, and the known benefits of doula care, which is represented by the orange bubbles on the right. Doula care is a non-clinical workforce that provides physical, emotional, and informational support through a person's reproductive lifespan. They can provide extensive prenatal and postpartum services based on the specific needs of the community. And in addition to care for reproductive health, some doulas can provide services that address health-related social needs similar to a community health worker. Perhaps what they're best known for, doulas also support individuals and families during labor and delivery. This could be at a hospital, at a birth center, or at home. In regards to the benefits of doula care listed in the orange bubbles on the right, doula care is connected with fewer obstetric interventions, less use of pain medication, shorter labor, and better breastfeeding rates. Research has shown that doula care can curb costs by helping to demedicalize childbirth, and studies have shown that doula care is a model for reducing the impact of racism and inequities for Black, Indigenous people of color. Next slide, please. Based on our stakeholder engagement, we do have some insights on the doula landscape of training and certification, reimbursement and payment, and the doula organizations and programs that are operating in Massachusetts. Doula training can range from a 1-weekend training to something like an 80-hour plus training. And after being trained, some doulas may seek certification. It's not a requirement necessarily for every doula role. Although there's no nationally regulated certification process for doulas, and many organizations do provide certification, an organization called DONA International is really the leader in this space. Doula care has not traditionally been covered by private insurance or Medicaid, which can create barriers to access for patients who cannot afford to pay for doula services out of pocket. Medicaid coverage has been piloted in some other states, and there's currently legislation pending in Massachusetts on this topic. Some health systems, including Boston Medical Center and Stewart Health Choice ACO, which I mentioned we've spoken to, have found ways to provide doula care for their patients. These programs may be funded through philanthropic dollars. They could be connected to ACO case management strategies. They can be supported by volunteer doulas, or they can be funded by other sources. The doulas within these programs can be reimbursed using global payments, fee-for-service, or some sort of combination of payment models. And finally, towards the bottom in this blue section, we've listed a few of the doula organizations that we know are operating in the Commonwealth, as well as some programs that are led by health systems. I'll also note that doulas can operate independently outside of any formal program or organization. Next slide, please. We've identified 4 key design elements and principles for our investment program. We hope to support comprehensive doula care models that provide extensive prenatal, labor and delivery, and postpartum support tailored to the needs of a given community, provided by a diverse and adequately supported doula workforce. We plan to focus on people of color, specifically Black birthing people, utilizing data to better understand where BIPOC people are receiving services to design a program that would support these populations. We aim to promote collaboration between doulas or doula organizations and healthcare organizations, including ACOs, hospitals, and FQHCs. This may mean facilitating new partnerships or supporting existing ones to better integrate the doula workforce. And finally, we will align with other efforts that we know are happening. Again, we understand that other organizations and agencies are interested in this model, and we'd like to align our work with those projects. Next slide, please. So here we have 2 examples of health system-based doula programs. On the left, which is a doula organization in partnership with an ACO, the doulas are employed by the doula organization. And in this scenario, an ACO case manager would identify a pregnant person eligible for services and would reach out to the patient to gauge interest. If the patient was interested, the case manager would work with the doula organization to identify a doula who matched the patient's preferences. This was really important in our stakeholder engagement, that the doulas match the patient's background or their various preferences. The doula would work with a birthing person through pregnancy, labor and delivery, and up to 6 weeks postpartum. In our hospital-based doula care model on the right, the doula would be employed by the hospital. A provider at an FQHC would identify a birthing person planning to give birth at the hospital. If the patient was interested, the provider would refer the patient to the hospital doula program, and the hospital would connect the birthing person to a doula who would then work with the birthing person just as they would in the ACO model. I'd like to emphasize that these are just 2 examples of potential care models, and they're not the only care model options. Next slide, please. With all of this information in mind, we're proposing the following investment program structure. As David mentioned in the legislative language, this will be a $500,000 investment program over the course of 2 years, which we anticipate will fund 2 pilot sites. The aim of the investment program will be to be increasing access to doula services as a means to mitigate known racial and ethnic inequities, enhance patient experience of care, and improve outcomes. The program will support birthing people, particularly Black birthing people, through the prenatal, labor and delivery, and postpartum periods. We've identified several key elements to the investment program that we're considering and would like to highlight for you today. Using HPC funding, awardees will provide doula services to target population birthing people during the prenatal, labor and delivery, and postpartum periods. Doulas will provide perinatal support and provide connections to healthcare providers, as well as social services providers and supports. Awardees will set aside funds for scholarships to train and support a more diverse doula workforce and incorporate implicit bias and cultural humility training for staff. We're also exploring ways to provide training and resource development related to the role, support, and impact of doulas. Next slide, please. This is our last slide. Again, we've been conducting stakeholder engagement now for several months, and we're aiming to finalize and release the RFP in early 2021 in the wintertime, and review and select awardees in the spring. So those are all of my slides. I'm opening up to questions if you have any. Thank you.
Jasmine, thank you. That was a great presentation. Chris, did I see your hand?
Yeah, thanks, Jasmine. So I understand you've got a lot of work to do between now and a presentation of possible awardees. But what's your guess? How many pregnant women do you think can be served by a $250,000 pilot?
I think that's something that we're still working on and fine-tuning to figure out how many birthing people would be served by the program, both due to the funding and also to the number of doulas who could be supported by a health system and hired in the time.
But any guess? Is it $1,000 per or $3,000 per? Or what's the in the current referenced example? Do you know what the number is?
Sure. For those referenced examples, we don't have exact numbers. Out-of-pocket doula services could cost anywhere from $500 to $2,000 per pregnant person. And some doulas offer various sliding scales. And then we do know that in states that have piloted Medicaid reimbursement for doula services, it's been around $500 per birthing person.
So theoretically, we might have a pilot of, or two pilots with a total of 600 to 1,000 patients to learn from these pilots. Theoretically, I understand we don't have the numbers yet.
Right. We're still working out exactly what that would look like.
Okay.
Thank you, Chris. Other questions for Jasmine? Don?
Thanks, Jasmine. This is very exciting. Can you say a word or two about the boundary of definition of what a doula is? And here's what I'm thinking. What would be the advantages and disadvantages of having the RFP refer to doulas and doula-like interventions? Do you think there's room for innovation here? Or is this a pretty well-defined package in which you prefer to see concentration on the concept as we currently have it?
I think that the training and certification for doulas really varies depending on the organization in terms of what they require. Some organizations we spoke to were really just finding people who had the right skill set and investing the time and money into funding trainings and things like that themselves. And even within that scenario, training could range again from something that's just a weekend to really substantial 80-hour plus trainings, in addition to certification programs that would require people attend a certain number of births and support them. So I don't think that at this point we have really decided if there are any limitations that we would place on what a doula is, but we do know that there is a lot of activity in this space, and a lot of people right now are trying to have conversations about the doula workforce, supporting the doula workforce definitions, tools for integrating the workforce and supporting a living wage. So I think this falls into our alignment category of understanding what else is happening in the state and figuring out where we can align best as possible to understand what those definitions might look like. Does that answer your question?
Yeah, it does. I think we're going to, the question for you is how much space do you want to create for that variation? Is there some box you want to put this in, or let us see who shows up and what? I don't know the field.
Definitely, yes. That's something that we can definitely think about further.
Other questions? Jasmine, thank you. That was a great presentation. This is an exciting new project. As you noted, there's still quite a bit of work to do, definitions to frame, an RFP to put together, and all of the bits and pieces that go into having a successful launch. So we will look forward to hearing more from you in the winter as you finalize the RFP and we get a better handle on how you've made your definitions and captured the outline of what the expectations are. So this is exciting, and we look forward to having awardees in the spring.
Thank you, commissioners.
Thank you, Jasmine. Okay, welcome. Kelly, are you back? Okay.
I am back. My apologies, commissioners. I think I had the, I think I just lived the standard Zoom stress dream right now. So
okay.
The complete loss of internet. So let me shift gears and bring us to our final agenda item. So last spring, when it became clear that COVID was going to have a profound impact on all of our programs and all of our health system partners, we began working with shift care awardees to try to understand and track the modifications that were being made to their care models to accommodate the realities of the pandemic. And that was true both of our opioid use disorder track, as well as our health-related social needs behavioral health track. In summary, what we found is that we have some really creative awardees who bent over backwards to develop novel solutions that allowed them to continue to support patients enrolled in their shift care programs, despite the incredible disruptions created by the pandemic. So with that, let me turn the discussion over to Caroline Knuthia and as well as Taylor Bungo, both of whom are part of our shift care team and have the pleasure of working with awardees on a daily basis, to introduce two of those awardees and let them share their stories. Caroline.
Great, thank you, Kelly. Hello, everybody. Good morning. My name is Caroline Knuthia. I'm one of the program contacts for the Shift Care Challenge awardees. The Shift Care Investment Program is an 18-month, $10 million opportunity to address whole person needs of patients and reduce avoidable acute care use through innovative care models. There are 15 awardees in 2 cohorts within Shift Care. The first has 6 awardees that are focused on addressing health-related social needs and behavioral health needs. The second has 9 awardees that are focused on expanding evidence-based opioid use disorder treatment capacity through emergency department and bridge clinics and facilitating timely follow-up care. Shift Care's implementation began in January 2019 for some of the awardees with an 18-month implementation period. So many awardees are wrapping up this fall. Today, we have the pleasure of being joined by representatives from 2 of our Shift Care awardees. Our first team is going to be Colleen Feeney, who's the investment director on the award, and Lee Hardy, who's a social work care manager from Community Care Cooperative, otherwise known as C3, who's in our HRSMBH cohort. C3 developed a community-based integrated care management program called Healthy Connections. Care managers enroll patients in their homes or other community settings to conduct in-depth health-related social needs screenings and to discuss the goals patients identified as the most important to them. Common program interventions include, but are not limited to, supporting patients to access housing, transportation, food, employment, and community-based resources. Healthy Connections was designed and is operated in close collaboration with the Brookline Center for Community Mental Health and Health Law Advocates. In addition to receiving support for clinical needs and HRSN, youth patients have access to HLA lawyers who provide navigation and representation with social services and education agencies. Our second team is going to be Dr. Mark Schechter, the investment director on the award, and Tina McLaughlin, the project manager on the award, from the North Shore Medical Center in our OUD cohort. North Shore developed a program that expands access to opioid use disorder treatment by offering medication for addiction treatment initiations for patients who have experienced opioid overdose or who screen positively for opioid use disorder in the emergency department and on inpatient floors. A care team, including recovery coaches, meets with eligible patients to discuss available care options and support services. North Shore is focused on building staff capacity and to prescribe buprenorphine and on implementing anti-stigma efforts throughout the hospital. We have invited C3 and North Shore teams to share with us the impact of COVID-19 on their shift care programs and discuss some of the challenges, ways they innovated, key lessons learned, and how COVID-19 may alter how they deliver patient care going forward. I'll have the C3 team start us off with their brief presentation, then North Shore will follow, and we'll save time for questions, comments, and open discussion with both teams at the end. With that, I'll hand it over to C3.
Thank you, Caroline. Good morning, almost good afternoon, everyone. My name is Colleen Feeney. I am the Director of Behavioral Health Programs at C3, working really closely with Lee and her team to operate the Healthy Connections program. So nice to meet you all and thank you for having us. Next slide. So what we wanted to do today, as Caroline had mentioned, a really big focus has been in our conversations with HPC around the implementation of our program as it relates to COVID and some of the impacts that it does have. As Caroline had mentioned, primarily a program which focuses on, meeting the health-related social needs and social determinants of health needs of a disadvantaged population. We have a team of 6 community health workers. And when you think of community health workers, you think of these workers in the community, meeting with patients face-to-face, whether that's during their point of care, in their homes, really whatever works for, the member. Our team has really been really creative in making sure that the services are brought to them. Obviously, when COVID hit, the whole world, including all of us, transitioned to a telehealth model. What we wanted to be able to demonstrate here in the data today was the enrollments that we were able to have by successfully enrolling a patient, so essentially a patient agreeing to participate in the program. And as you can see, pre-COVID, as a program, we had 81 enrollments. This program started in June of 2019. So, if we're to think June of 2019 to basically the end of March, 2020, about, 9 months or so, we were able to get 81 enrollments. So from April to September, the team of community health workers was able to obtain 182 enrollments, which really speaks to the large increase, as you can see just there in the data, that the team was able to make sure that they were continuing to bring patients the services during what we all know was a very vulnerable time. We believe a lot of this was, in part to a lot of patients being home, right? And us being able to successfully connect with patients a little bit better. But then also, again, like I mentioned, the vulnerable needs of the patient population. We also had a lot of enrollees who maybe previously didn't engage, who would then reach out to our teams during this time of need. So really wanted to be able to demonstrate that our team of community health workers was able to continue to provide the service and help support patients with social determinants of health needs, and at a much increased rate comparatively to pre-COVID. We also wanted to be able to identify some of the reasons that our case, that in terms of case closure, how we track patients who are closed from the program. And we wanted to call out 2 specific closure reasons, or reasons that a patient would be discharged from the Healthy Connections program. One of them being goals met, and one of them being lost to contact. Obviously for goals met, that is our program standard. That is our absolute goal as a program, is to be able to work with patients from the start of patient identification through discharge and help them reach their identified goals. So pre-COVID, that was a 20% rate, and that, we have gone up 20%, and now 40% of the patient population at that point, post-COVID, had goals met as their closure reason. And then for lost contact, we obviously want to see a decrease in that, which again speaks to the work that the team was really doing to make sure that they were continuing to stay connected to patients via telehealth. I will pass it off to our manager of our Healthy Connections program, Lee Hardy, to talk a little bit more about the qualitative aspects of the program and what we've seen since COVID.
Hi, everyone. Yes, please, next slide. My name is Lee. I am a social worker, and I'm the manager who supervises our team of community health workers. We also have on with us as well, Kristen Falvey, who's our community health worker from the Worcester area, and who joined our team right as we were transitioning to telehealth. So she really learned this job primarily doing telehealth support. And I'm here to share some of our lessons and values that our team learned from our Healthy Connections program experience. And so the first one is that in that previous slide, the majority of those enrollments were cold calls. We were calling people who were lost to contact or unreachable in other programs, and we really did have a lot of efficacy in just cold calling people. The next lesson we really wanted to emphasize was how housing was experienced by our team. Housing was one of the most common health-related social needs reported by the people we serve. It was also the most stressful one reported by our members, and our community health workers really expressed how stressful it was for them, because out of all the health-related social needs they were helping people with, it was often the one that they had the most challenges progressing on. The next lesson, as was mentioned in the beginning in describing the model of this program, was we really want to emphasize how important the legal integration in this model was for us. Having in time information on changes with immigration reform, changes in policies with social benefits, changes with special education and the education system right now with COVID. All of these were important moments where our legal integration we really relied heavily on, and we're really grateful that we had that connection. And the last lesson is really to emphasize how important the role of community health workers are in trying to find more efficient interventions, particularly with vulnerable and unreachable populations. Next slide, please. The values that we'd like to emphasize from our experience are first the examples that we have of ER and inpatient diversion opportunities. One of the things we emphasized a lot in our reports with the HPC were these examples of what seem like little interventions, which really have a big impact, which we'll give a couple of examples of. And then wanted to encourage the exploration of seeing how much value do community health workers contribute in how they impact reducing missed appointments, and just wanting to highlight that as a possible value to explore more. Next slide, please. So just to start with a couple of examples of the little big, when we talk about little big things, in this time of COVID, when we are working with very vulnerable populations, particularly our young people who right now are experiencing, for example, isolation many times, in having to be home and don't have some of the connections or activities that they're normally used to in their routine. We connected with the DJ Dream Fund to try and get some resilience activities into homes that we were, or in the hands of members that we were working with. A recent COVID example is a mom that we're working with who is currently home with her 8-year-old son who is diagnosed with autism, who is nonverbal and also needs to use diapers. And she's providing 24/7 care now for him and struggling financially. So we were able to help bring some sensory activities for her son to provide some relief while we sort of work on these other larger issues. We brought arts and crafts, karaoke machine, musical instruments. So this has been a great just opportunity to bring some concrete resilience tools into homes at this very vulnerable time. Next slide, please. Another example of a little big thing is one of our community health workers who speaks Cape Verdean Creole engaged a member who did not have a income for 2 years prior to engaging with our program. And there was a lawyer working on an SSI appeal, and because the community health worker was able to bridge a language gap, that member started receiving $850 in SSI. And that member's daughter, who had been helping this member out, now can invest that money that she was helping her father with to her own daughter. Next slide. When we talk about ER and inpatient diversion, this is one example of a member that, because of the therapeutic rapport I developed with this member, they would call me when they were in the ER, and we would be able to help develop a more appropriate and effective discharge plan than inpatient, which often was not beneficial to this member. And that would often result in either discharge from the ER or, for example, CSU level of care. A COVID example is we recently had a mother who had been in a car accident with her son and was concerned at the night after being discharged from the emergency room about how her son was presenting. And she was having a hard time juggling, getting through to the PCP, dealing with insurance, getting a rental, and trying to observe what was going on with her son and gauge what was going on with him and if she should be concerned. Because she had developed a therapeutic rapport with our community health worker through the health-related social needs work, she called that community health worker. We were able to triage with our nurse on our team to help do an assessment and immediate kind of safety plan and triaged with the health centers because we have that connection as C3, and helped triage with the health center to make sure this mom had her connection with her PCP and felt like she had a plan that supported her and her son. And this is an example of not only better quality of care for this member, but as well as avoiding quite possibly an ambulance or ER presentation. Next slide. And so to end with just emphasizing the elements that we identified as crucial to the Healthy Connections model that helped produce a lot of the examples that I just gave. First, the flexibility of having a smaller caseload than the other programs at C3 was really highlighted as a reason why community health workers could be flexible in meeting the needs of members. The other one is that the focus of our engagement was on health-related social needs, which we think possibly, particularly in the time of COVID, helped us engage better with members. And the last is just the impact of the community health worker role, which really is this unique combination of the lived experience with very strong therapeutic rapport skills, which in reference to the examples that I provided, really illustrate how you can have much more efficient outcomes, interventions with vulnerable populations and populations that are often found unreachable. And next slide.
Awesome, and I will take it from here. So what we wanted to do, just very briefly talk about our next steps as a program. The 18-month implementation period does end at the end of October. However, we have decided that the 6 community health workers will continue to work with eligible patients who screen positive for social determinants of health needs through December 31st of this year. We have a projected date of November 2nd to stop taking referrals so that we can try to make sure that we see through the action plan that we identify for patients through December 31st. And I think that that may also change depending upon the overall caseload of enrolled members that the community health workers have. And we will work very closely with HPC and Wendy on the reporting aspects that only through 10/31/2020, even though the program will continue. Thank you, Caroline.
Thank you for a very encouraging and enlightening presentation. Let me open it up to the commissioners and see if there are any questions. Chris.
Thanks. Could you give us a little understanding of the kind of typical training or the average training of a CHW? By who, how long, by whom, how you measure the quality of their work, but I'll just let you go.
So on our team, we actually have a range of experience in sort of formal helping relationships with the populations that they live in. All of the community health workers, I will say though, have personal experience providing help, particularly with applying for social benefits, navigating systems like special education systems or school systems. And so we have on our team, everyone has personal experience. Some of them have also formal experience as a community health worker, as a patient navigator, or in some other type of formal role. But for example, we have a community health worker who is actually more in the business field, and because of their personal experience doing this in their personal life, wanted to become a community health worker, and this was actually their first job as a community health worker. That was actually the person who was the example of who worked with the person and got the SSI. What I will say is, again, want to highlight the emphasis on therapeutic rapport, that this isn't just about lived experience. It isn't just that you have this experience, but just as I, as a social worker, would look for therapeutic rapport skills, and if I was interviewing for social workers, similarly, I looked at for that when I'm looking for community health workers. In addition to you have to, as a community health worker, you're not only going to work with the population that you maybe have personal experience with, so you do have to be very flexible and open-minded in your skills to engage with a very wide range of populations with a wide range of identities. So those are the skills that I'm looking for and then continuing to develop. Also, we joke a little bit that community health workers should be private investigators because a lot of it is detective work. People who know how to continue to follow leads, are diligent and continuing to call, who have patience with systems and bureaucracy, and know how to just keep at it. So I would say those are kind of the wide range of skills.
Okay.
Once they're with us, we then have a training, obviously, as C3 community health workers with that.
Okay. And how much are you paying them on average?
Colleen, if you want to share that.
Yeah, it's their current salaries are between 45 and 50,000.
Thanks. Congratulations on your success.
Thank you.
Thank you.
Are there any other questions or comments?
Barbara, it's, I think a great presentation, wonderful job. I'm struck by your observation that it's the little things that make such a difference. And, you know, those costs compared to the healthcare costs, those are pretty cheap, but have delivered big outcomes. I just wanted to sort of think about that first slide that you presented, which was how many people you lost contact with. And I don't want to focus on the negative, but have you sort of looked at why folks became sort of lost to the system? Was it, did they move out? I'm just curious as to what some of the reasons you think folks end up being lost in such a robust system like this.
So the primary reason is we serve a primarily homeless population. So most of the people that we're trying to sustain engagement with are homeless, many of which who don't necessarily have cell phones also. So some of these people we then regain contact with. They either call us back down the road or we do continue to reach out to people. Also, if they get rehospitalized. So if they are hospitalized and someone sees in their chart that we had a case open with them, they will reach out to us and say, hey, I know you're trying to engage this member, they're in the hospital. And if we can catch them in the hospital, even if they don't have a cell phone, we can often get, okay, do you have a case manager you normally see? What shelter do you go to? We can try that. But it's I would say the top reason, there's other ones, but and we hear this from other programs, is that when working with a primarily homeless population, that sustained contact is very difficult.
That makes sense. Thank you.
And I think just the other thing, because your population is homeless, one of the things that I've learned is that it takes a while for a homeless person, a homeless family to feel safe enough to trust. And that ability to offer consistency is a critical factor in breaking through that barrier that actually engages people in the kind of meaningful way that gets them the best possible progress. I love the comment about little things having big impacts. I mean, I think we often think that something is so little that we might take it for granted, but they don't. It's not taken for granted because it's not there. And so I really like that component of your work. I have a lot of respect for community workers. They saved me many times in my early part of my career. I'm not sure I'd still be around if it wasn't for them. They did wonderful work in teaching me, and I will forever be grateful to what I learned from them. So, keep up the good work. Community workers are a huge benefit that I think we still don't completely understand how it is that they make the difference that they make, but they do, and they're remarkable. Thanks, Leah. Caroline, you have an exciting program that you're working with.
Absolutely.
Anything else that you would like to share with us before we conclude this part of our program?
Oh, and we'll be ready to have the North Shore team also do a quick presentation as well.
Perfect. Okay. So let's move on to North Shore.
A quick suggestion, this is just totally accidentally, but I had a long meeting with the Camden Coalition yesterday, doing some of the same innovations that you're doing, including reaching over to medical legal partnerships. So I'd be happy to help make that connection. I think they would help. They would learn from your work, and you could learn from them.
Thank you, Don. Caroline, why don't you do the next introduction?
Great. All right. So we're going to have Dr. Mark Schechter, who's the investment director on the award, and Tina McLaughlin, who's the project manager on the award, talk us through North Shore's OUD program. So handing it right over to you.
Well, Tina's going to kick it off, and I just want to let people know I'm going to have to jump off right after because I have my clinic scheduled in a few minutes. Tina, you start.
All right, great. Thank you. You can go to the next slide, please. So my name is Tina McLaughlin, and I oversee community benefits at North Shore Medical Center. I'm just going to take a few minutes to provide an update on our shift care program prior to the COVID pandemic, and then some of the changes that we have made since the spring in response to the pandemic. And then I'm going to turn it over to Dr. Schechter to share some of our lessons learned and opportunities moving forward. So the timing of our shift care program worked perfectly with the strategic planning process at North Shore Medical Center. So we, back in the fall of 2018, our hospital went through a strategic planning exercise, and we identified 4 strategic priorities for the hospital, one of which was to improve care and reduce stigma in patients with substance use disorders. So having our shift care program be aligned with our hospital strategic priorities was enormously helpful. There was a steering committee that was established with over 20 people from all different parts of our organization. And it also coincided with a hospital-wide anti-stigma training that we implemented in partnership with the National Alliance on Mental Illness. A second key component of our program was our recovery coaches. So similar to the presentation we just heard from C3 and the value of community health workers, our recovery coaches have become a very important part of our care teams. And they were connecting with, throughout this entire program, they've been connecting with between 100 and 150 ED patients every month that come through our emergency department with a substance use disorder. They've also been enormously helpful in terms of de-escalating situations in the emergency department. A challenge that we faced related to the recovery coaches has been around long-term financial sustainability, since we are not able to bill for their services. However, we did recently get notification that through the Healing Communities grant, we are going to be able to continue funding for our recovery coaches at the hospital for at least the next 18 months. So thinking about long-term, given the incredible value that recovery coaches have on our care teams, figuring out a way to have them part of our care teams, well into the future beyond our next grant is enormously important to us. The third thing I wanted to emphasize is that pretty early on in our program, we realized that the engagement rates, treatment engagement rates were higher for our inpatients than for our emergency department patients. So we pretty quickly shifted our focus. We still tried to engage patients when they were in the emergency department prior to discharge, but we realized that our real opportunity to successfully engage patients in medication-assisted treatment was on the inpatient side. We did offer all of our hospitalists and ED physicians the opportunity to get their DEA-X waiver, and I think we achieved basically 100% compliance, which was terrific. We also developed data dashboards, which were enormously helpful in having us figure out where the real opportunities were for improvement. Next slide, please. So in response to the COVID pandemic, so like many hospitals, we experienced a significant reduction in ED visits when the pandemic hit. So the volume of our treatment eligible patients that came through our emergency department was significantly reduced in the spring. However, we were able to immediately transition our recovery coach program to operate virtually. So every patient that came through our emergency department, even though our recovery coaches were not physically on site, they followed up with the patients after their ED visit and found that they actually were able to engage in some cases, more patients than they were able to on site in the emergency department. There were some patients that actually felt more comfortable engaging with a recovery coach by phone from their own comfort of their own house versus in an emergency department. And we also, another thing we did is we continued our substance use disorder steering committee meetings. So, many of our meetings throughout the hospital were canceled in the spring as we were all so focused on the COVID pandemic. One of the few steering committee senior leadership meetings that continued was our substance use disorder steering committee. We continued to have those meetings monthly via Zoom, so that was enormously helpful in terms of keeping our program on track. And then in recent months, our ED volume has increased. Again, our recovery coaches are still available to everyone, all of our substance use disorder patients virtually. And we have noticed an increase now of treatment eligible patients, particularly inpatients in the last couple of months. So I will turn it over to Mark.
Next slide, please. Yeah, so I'll just take a couple of minutes just to emphasize a few things that Tina shared already. One is it's been so critically important that this initiative has aligned with hospital senior leadership priorities as clearly identified in the strategic plan. The support across the organization has been enormous. We have learned, and this was, I'd say there are a couple of things that we learned that we didn't expect. One was that we have been less able to engage patients in medication-assisted treatment in the emergency department than we expected, more so on the medical surgical floors. And I think that when we thought about this at first, we were very focused in our own minds about medication-assisted treatment, which is obviously essential. But I think we did not appreciate the important role that recovery coaches would really turn out to play in connecting people to a human being and connecting people to care. And even if they're not quite ready for medication-assisted treatment, to have them have a link and someone who can hang in with them and transition with them into the community and help them wherever they're at to reach out for whatever they're ready for, or even if pre-contemplative, just to stay involved with them. And the other thing about us, which is unique, is we're a full-service medical hospital, but we have the largest psychiatric department in really any full-service medical center that I'm aware of. We have 114 psychiatric beds, and our ED is absolutely full of psychiatric patients. And what we found is the recovery coaches have been an incredible addition to our inpatient psychiatric team as well. And while we provide substance use disorder care there, it has been stepped up enormously by the capacity to connect people in real time with recovery coaches while inpatient. So when we talk about inpatients, we're really talking about the medical surgical side, but also the inpatient psychiatric side, since we have such high volume there. And at least 50%, if not more, of our patients have comorbid substance use disorders. And in fact, many of them have primary substance use disorders that are driving their depression or suicidality because of the other concomitant problems that come with their substance use disorder. So just again, the importance of the recovery coaches has been an enormous learning experience for us, and we're looking for ways to make that a really sustainable thing. We have worked as hard as we can on stigma, both internal to patients and external in the organization, the community, because that's definitely a barrier. And we found it really useful to have these data dashboards that we can look at monthly with the Substance Use Disorders Committee and oversee how we're doing. Next slide. So looking ahead, I think, as I've already said, we've broadened our view from the emergency department to really now what we're thinking about is how do we do the same kind of thing? How do we bring kind of wraparound care to patients at all levels of care, including in the primary care office or the outpatient psychologist clinic, or the partial hospital program that we have for psychiatric patients, the emergency department, the medical surge side, that really we need to try to move this to wherever the patient is struggling with substance use disorder and not wait for them to end up in an emergency department or in a hospital. We are finding, this is not, I guess this is a segue from some of what we're talking about, but one of the things that we're learning is that our emergency department, as the Mass General's is just getting busier and busier and busier with psychiatric patients who have nowhere else to go. And I'm on a call with Mass General Brigham leadership every single morning, and we're looking for who has beds, and we do not have enough beds despite our expansion here to find homes for these patients. What's happening is a lot of them are boarding for long periods of time, and unfortunately there isn't really a model to provide, and there's no support for what care should be delivered there as opposed to their boarding. Could we get away from the idea of boarding, and could we start doing acute treatment? Bring the clinical social worker, bring the psychiatrist, whatever's needed. Let's start treating them in the ED and treat it as if they were in an inpatient unit. That's theoretically possible. With current resources, it's not really possible, but I wanted to bring that to the committee's attention because I think the Department of Mental Health, trying as hard as they can, just the idea of, well, you know, trying to push hospitals to take patients faster, that's a limited, very, very, very limited strategy. The hospitals are full. You know, if we could take people faster, mostly we would. And some of the patients who are really stuck in emergency departments, sometimes they're stuck there for reasons because inpatient units are unable to manage them for one reason or another. They've got too many other aggressive patients, and this patient would just be one aggressive patient too many. I think if we could pivot to accepting the reality that we're providing a lot of psychiatric care in the ED, and then go for it with some kind of support and maybe the kind of model that you've used with these grants, I think that could be a real pivot point. We are working on geriatric outpatient services. As you know, the population's getting older, and that, at least for us, it's been very hard to find placement in the outpatient world for our patients with dementia and other older folks who we discharge from our geriatric psychiatry unit, or we see in the emergency department or in our primary care practices. There just aren't that many geriatric psychiatric clinicians out there. So that's an area that I think as a field we need to look at. We're certainly getting started with that now. I just hired a geriatric psychiatrist to get us started there. The ED problem is in part because of psychiatric patients, and it's also because there's just a flood of patients who have primary substance use disorders. I'm not sure we have the right number of detox beds in the state to take care of those patients. Certainly at North Shore, we have those patients boarding for a long time. And there are theoretically other levels of care, like EATS levels of care. So the payers will say, well, this patient's EATS level of care, meaning it's a residential care, doesn't quite meet inpatient. But the reality is there are so few of those that really means 24 to 48 hours of living in the emergency department until you can argue with them to bump it up to inpatient. So there really aren't the right resources for those patients. Teens don't quite have the access that they need. We really don't have a specialty program here. We don't know of any others around for teens with substance use disorders. And we've recognized that while we're dealing with the social determinants of health and we're sensitive to them, we're not really screening people in a proactive way when they come into our points of care of housing, food security, transportation issues. And it has occurred to us through the course of doing this grant that that's something that we and probably the field could do better at in terms of proactive screening. And I'll stop there. Unfortunately, I'm really late for my clinic, so I'll follow up with Tina about any comments or questions, okay? Thanks so much.
Thank you, Mark. Appreciate your time.
Thank you. Bye-bye.
So, questions for our team. This is exciting stuff.
Barbara, as the behavioral health member of the commission, first of all, great work. Glad to see that you're going to be able to continue it. Last slide is the perfect to-do list for our healthcare system for behavioral health.
Thank you, Marty. Tina, in the work that you've done to date, has anything surprised you?
I guess there's a couple things that come out in terms of what has surprised us. So as Mark mentioned, it surprised us how few patients were willing to engage in treatment at the time of their ED visit. You know, we had all of our ED providers get their DEAX waiver, and you know, we have Suboxone kits that we're able to distribute to patients that they can initiate at home, and then, you know, set them up with a follow-up appointment before discharge. But we thought that we would be engaging a lot more patients at the time of their ED visit before discharge. But we have found that patients that are in our emergency department, you know, at the time of an overdose, once they are medically cleared following their overdose, they are very eager to physically get out of the emergency department. So it is not the time that they they seem to be willing to have discussions about engaging in treatment, which is why on the inpatient side, you know, the situation is different. We were able to then have recovery coaches and other specialists, you know, round with the patients, talk to them at different points, and had a much you know, we're much more successful because we felt like they were more motivated and sort of willing to sort of be attentive and think about engaging in treatment when they're on the inpatient side. So I think that was probably the thing that surprised us the most, is how difficult it is to engage patients in MAT treatment at the time of their ED visit.
I think, you know, I've seen that as well, and from my experience, I suspect that what happens is that when they lost consciousness, they were having the best buzz of their life. And when we gave them Narcan and we neutralized everything, when they woke up, they were in complete withdrawal. And that is not the time, as you say, to try to have any kind of conversation with them. The trick is to find the place where they're vulnerable to hearing what you have to say. And fortunately, you have the inpatient unit, which does a tremendously important job, but it's a site where you can actually do the engagement. So that's a critical component to your work. Other questions? This is great work.
Hi, this is less a question and a comment, and just a note of gratitude and thanks to the two programs that presented here today, and for your work throughout this incredibly disruptive period. And Lee, I think, mentioned some of the characteristics that make community health workers so successful: patience, determination, flexibility. I think those characteristics also apply to the recovery coaches in this program, Tina, and more broadly to the leadership of these programs in being patient, determined, and flexible to continue to serve the needs of your communities during this disruption, and using technology in really interesting and innovative ways for, you know, very difficult to serve, but patients. And so a note of kudos and gratitude, and really happy to see the emphasis on using people in the care team with lived experience, and how important that can be for making patient connections. So less a comment and more of a note of thanks.
And Tina, again, thank you very much. And a very exciting program. I think at this point, if Kelly is with us, there you are.
Yes,
Hi, Kelly.
there I am. Yep.
We have briefly some announcements about some exciting publications coming up.
I will make this very quick. If we could go to the next slide, please. There we go. As David mentioned at the start of the Market Oversight and Transparency Committee meeting, September is a meeting with many, many publications. I want to draw your attention to a couple in particular because they are relevant to the discussion we had today. One is the HPC certified ACO profiles, as well as data points on HPC certified accountable care organizations. Also, just note the policy brief that aligns with Sarah's earlier presentation about serious illness. Lots of really good things here, but I would be remiss if I did not acknowledge on this last day of September, or as we have been calling it, Chartember, two really important publications that relate to our CHART investment program. First is the CHART Phase 2 evaluation report, which is I would say is the most comprehensive look we have taken on the impact of that program. And then also the CHART playbook, which just does an amazing job of harvesting incredible learning from the CHART participating hospitals and organizing them in such a way that we hope that many organizations can take full advantage of the experience. So lots of really great things here, all available on the website, and we really encourage you to take a look.
Thank you, Kelly. Very much appreciate that. David, let me bounce this back to you for your closing comments and thoughts. And
well, just a note of gratitude and thanks again for our guests who presented today. And thank you to commissioners. This was a jam-packed 3 hours, but really, we're just so pleased to be able to present on this information and on these programs, and appreciate your dialogue. And for those of you who made it through the full 2 meetings, this will be good practice for the cost trends hearing. So you'll know now to keep the water bottle and the granola bars nearby. But really, Commissioner Blakeney, Commissioner Cutler, who chaired the previous meeting, thank you. And